We're going to get started right away. So we're going to hear from our prime sponsor of SB 609. And Senator, you are recognized whenever you're ready.
Thank you, Mr. Chairman. Good morning
there you
to
go.
the Senate Health and Human Services Committee. For the record, my name is Sharon Carson, and I have the pleasure of representing Senate District 14, which comprises the towns of Auburn, Londonderry, and Hudson. And I have for your consideration this morning Senate Bill 609, relative to improving screening for and treatment of blood clots or venous thromboembolism and establishing a statewide venous thromboembolism registry. Mr. Chairman, this bill is a result of communication with a constituent who is here today to talk with you. And I've also handed out a copy of the law that was passed in Florida, so you can all take a look at that law as well. So I have filed this legislation on behalf of a grieving mother who tragically lost her daughter Katie to a postpartum blood clot. After the birth of her first child, Katie left the hospital with no discharge counseling or blood clot warning signs, despite being at an elevated risk for them due to the circumstances of the birth. She was also not even informed that she was at an elevated risk for these types of blood clots. This piece of legislation is intended to save the lives of mothers just like Katie. Blood clots are a leading cause of maternal morbidity and mortality, even more so when postpartum education and system-level safeguards are missing. Granite State mothers with risk factors such as C-sections, preeclampsia, or prolonged labor deserve targeted screening, education, and systemic support to prevent avoidable loss. This bill takes an important step in stopping these preventable deaths by requiring that hospitals, ambulatory surgical centers, and emergency medical care centers develop a screening and treatment plan for these types of blood clots, which are known as VTE, in women who have just given birth. This bill also directs the Department of Health and Human Services to contract with a qualified nonprofit to establish and maintain a statewide VTE registry. The registry will collect anonymized, so everything will be anonymous, data on diagnosis of VTE for the purpose of improving treatment for the condition. The goal of this bill is to save the lives of mothers in our state and to generally increase awareness and education of this condition. Thank you very much, Mr. Chairman. I'm going to conclude my testimony at this point. As I said, the constituent who asked me to file this is here, and I'm sure she can probably answer your questions more than I can, and as well as the Department of Health and Human Services. But if you have questions, I might try to answer them for you, but.
All right, thank you. Are there any questions from the committee? Senator Prentice.
Thank you, Senator Carson. And this might be for the department. You talked about the registry, and there's no fiscal note with this, so it's going to run through a not-for-profit. Would the state be funding that through the not-for-profit? I'm just trying to understand. Registries I'm just curious about the cost.
Okay, thank you. Senator, I was surprised that there wasn't a fiscal note bill, fiscal note attached to this bill, because I'm sure some money is going to be needed someplace. And so the department is here, and perhaps they can give you a reason why there's no fiscal note on it.
I mean, we do have, if I may.
Yeah, absolutely.
We do have, some other registries. So there maybe their thinking is to kind of shoehorn, to put this together.
Yep.
Use the infrastructure that they have. So I was curious about that. Thank you.
I was also curious. So thank you, Senator.
I just have a quick question before you leave. Looking at page 2, line 20, as far as the data collection, the zip code of the patient, I didn't know if you'd be open to a friendly amendment to maybe change that to the county. I know in my constituency, I've got zip codes with very, very few people in it. And just a consideration.
Mr. Chairman, this bill belongs to the committee, and if you see fit to have an amendment, that's okay with me.
Thank you very much.
Thank you.
Thank you.
Thank you very much, Mr. Chairman.
Okay, the chair calls John Williams.
Chairman Rochford and members of the Senate Health and Human Service Committee, good morning. For the record, my name is John Williams. I'm the Director of Legislative Affairs for the Department of Health and Human Services, and I'm privileged to be joined today by.
Good morning. My name is Kelly Keefe, and I'm representing DHHS Licensing and Certification for Health Facilities.
And I think that Senator Carson did a very good job of laying out what the rationale was behind the bill. And I think certainly when you hear the testimony of people who are impacted by this, it will give us even a better understanding of the importance of the issue around blood clots and perhaps also for establishing such a registry. We were, believe it or not, and it is a mystery to us as well, that there was not a fiscal note that was added to the bill because we were requested back in October to doing a financial analysis. So we did have some information that we can provide to the committee. I will say, however, as part of our fiscal analysis, that we ultimately made the assumptions based upon the four corners of the document of the bill that this private entity, this nonprofit, would be charged with the expenditure so that the department, other than being charged with entering into the contract process, which we do as a normal course of our business, that the burden in terms of the costs associated with standing up the registry would be borne by the private entity itself. And so we were looking to getting a better understanding of who that private entity is that's out there. And my understanding, and perhaps it's in the materials that the Senate President provided to you, that there apparently is a vendor, is my understanding. Again, that's based upon, this is good lawyer legalese when we don't know it directly, but upon information and belief, there is a vendor that is out there that would do this. Now, the question also arises about, how can we put language in the bill that somehow safeguards the department to ensure that, for example, if that nonprofit entity were no longer to exist, or they couldn't meet their financial obligations, because in addition to entering into a contract with us, there would have to be, obviously under contract law, offer, acceptance, and consideration. And so because there's no money associated with legislation itself, it would sound to me that this private entity would be bearing the full cost and responsibility under the contract for doing this. It does raise some certain questions regarding your outreach perhaps to the Office of Professional Licensure and Certification, because there may be some involvement in terms of their regulatory oversight over at least the provider community, and certainly we're on the facility side of the conversation. Also, as part of our fiscal analysis, when we reviewed the bill and made the determination that there would not be a specifically direct impact to us, again, because those costs would be borne by this private entity that's out there. The other consideration outside of the scope of the department is the provider community themselves. What costs would there be associated with them standing up a particular registry? Because this is our understanding. We as the department would not be actually standing up the registry. It would be this private entity that's out there, and upon information belief, this is something that they're already either engaged in or seeking to be engaged in other jurisdictions. As Senator Carson mentioned, that the model came from the state of Florida, and again, from her materials, it might answer some of those questions. I would like to stop talking for a second before taking questions, and then also I just want to ask Ms. Keefe, because she is a wealth of knowledge, and I probably missed something in my very high-level overview of the department's review of this legislation. And I do have a suggestion for some amended language as well as soon as you're done, Ms. Keefe.
I think you covered. I have nothing to add. If you have any questions, I'm happy to take them.
Just note, if you do have a recommendation for some language on an amendment, if you could send that to me, I would appreciate that.
We will do that. And in the same way that you had mentioned on line 20, changing and again, my understanding would be this would be de-identified information that would be provided. And very similar to what we see in other reporting data, changing a zip code, which we know can, and particularly in rural areas, get more discreet in terms of personal identification, that we see county as being, so that seems to be a reasonable suggestion on your part. I'm just looking at Ms. Keefe, who actually knows this herself. So now I actually can say not upon information belief, but because Ms. Keefe said so. On line 31, I would suggest in Roman 4, and I will provide you with specific language. Oh, yes, that would help. Page 2. On line 31, where it talks about the reporting, it talks about, just before the reporting requirement, it talks about the department shall require the contracted private entity to do the following. I think at the end of that, the last sentence there where it ends with data collected, if we added a separate sentence that talked about traditional standard safety valve language, that in the event that the private entity no longer exists or cannot meet their financial obligations, or there is not sufficient funding for the department to stand this program up, that there will be no obligation to proceed. I'm going to stop with that because there's better language other than what I'm just about to spout out that I can certainly provide to the committee.
And I'm confident you'll send that to us.
We certainly
In
will.
writing. Very good. I think Senator Avard has a question.
All right.
Well, I'm just kind of, you know, I like what the bill is doing, but I guess my question is, shouldn't this already be done? Shouldn't there already be screenings? We have to make a law to make it happen? Is that?
Yes, it should in clinical practice already be done. That should be part of their assessments. And those regulations would be OPLC. They enforce and regulate the clinicians. So each hospital likely already has policies and procedures for assessing, triaging, and treating. So yes, I agree.
Follow up?
Yeah, so couldn't this be like an endless list of things that we should be telling them to do?
And I do think this is why I set out initially that I think outreach to the Office of Professional Licensure and the various boards that would be impacted, or perhaps if there's somebody in the gallery from the hospital committee that might be able to provide you with some information about what currently is being done might be helpful to the committee. But with that said, certainly this is incredibly important legislation being requested by the Senate President. We do think that there's a need to getting some safety valve language in here in the event that it can't be stood up. We're here as a resource, not taking a position on the bill, but others might have a very different perspective to provide to you.
An apprentice.
Thank you, Chair Rochford. John Williams, I'm concerned that you're not breathing in between your sentences, so take a deep breath, relax. So, you know, I actually was going to ask, I want to do a follow-up on Senator Avard. Having been someone who's worked in an emergency department in particular, people that we discharged there were determined to be at risk. They had counseling because, you know, it was either the provider or I, as the one who was discharging them, did that and then gave them paperwork. But I can't speak for what happens on the floors. Do we have an inventory of what, this might be for the Hospital Association, of what the practices already are? I mean, this is very important, but I just want to know that.
I do think that we should defer to the Hospital Association if they are available and to answering your questions. And to the extent that Ms. Keefe, who does have a better understanding, she may be able to provide some limited, but with the understanding that we are not the source authority on the response to your question.
Okay, just one other quick. Ambulatory care data set and outpatient data. There are two data sets, one that I believe runs through your department and one through the Hospital Association. Is any of this data already available in one of those two sets? Maybe you can check into it and let me know. I'm just.
So that would be under the adverse events.
Okay.
And they are obligated to do that. So hospitals and ambulatory search.
Okay. Thank you. Thank you, Chair Rochford.
Any further questions? Thank you very much.
And thank you.
Chair calls Diane Morissette.
Hi, thank you for having me. My name is Diane Morissette, and I'm from Auburn, New Hampshire, and I'm here in strong support of SB 609. Senator Carson did a great job explaining a little bit about my story. My daughter Katie did die from a postpartum pulmonary embolism, a blood clot, after the birth of her first child. She had multiple known risk factors, including the prolonged labor, prolonged difficult labor, a C-section, and then she also had postpartum preeclampsia. we talked to the doctors in the hospital briefly because our knowledge was not there. But she had a lot of swelling, and to me, blood clots relate to swelling. And we asked, should she wear compression socks? And it was not even a consideration that blood clots were a thing. So to answer some of your questions, what is supposed to be happening or what might supposed to be happening, it didn't happen in my daughter's case. So despite the red flags, she was discharged, and the next day she passed away suddenly. No one told us what to expect. We even called the doctor back about her high blood pressure, thinking that maybe the preeclampsia was part of the issue. And I think education on blood clots for doctors is very important because the symptoms overlap a bit, and I do think they kind of brush it off to high blood pressure. But I do believe that that blood clot was forming, and ultimately that was what she passed away from. As I was advocating for her death, I did work a lot with maternal health organizations. I met a lot of women who survived, which is wonderful, but pregnancy is definitely a huge risk factor for blood clots. But what I've also learned is that it's not just pregnant women. So many young people have died because it's just overlooked. It's not considered, they're considered too young or low risk. A similar act that was passed in Florida for Emily Atkins. She was 23 years old and her pulmonary embolism was also preventable. And it reveals the same systematic gaps, missed risk assessment, lack of education, and delayed recognition. So SB 609 matters because it focuses on prevention at the system level. When hospitalized, use standardized risk screening, provide clear discharge education, and ensure provider awareness. Blood clots are more likely to be identified early before they become fatal. These are practical preventative measures that support clinicians and protect patients. Blood clots remain the leading cause of preventable death, yet awareness and education are inconsistent. SB 609 helps close these gaps by creating clear expectations and safeguards, especially for the high-risk patients and young people whose symptoms are too often dismissed. Katie's death was preventable. With better symptoms and informed patients, lives can be saved. I respectfully urge you to support SB 609. Thank you so much.
Thank you very much. You willing to take a question?
Sure.
All right, Senator Abar.
So in your, advocacy of this, you've seen studies of what's going on, I'm sure. Are you able to provide the committee with like long-term studies that this has been a problem for a while, or has this just been a recent spike? It's a tragedy of your loss.
Thank you.
But has this been going on for a while?
I don't know. I've been seeing more cases as opposed to studies because I'm just hearing other moms' stories or patient stories. Most of them have been in the past few years because that's where I'm finding the groups through Stop the Clot, the National Blood Clot Alliance, and then Mama's Voices is another organization that I meet a lot of women through.
Yeah. Thank you for taking my question.
Any further questions? Thank you very much.
Thank you.
Let's see, Chair calls Ben Bradley.
Morning, Mr. Chairman. Members of the committee. For the record, my name is Ben Bradley, Vice President of State Government Relations for the New Hampshire Hospital Association. We represent all the state's community hospitals. I just want to extend my sympathies to Ms. Morissette for the loss of her daughter. The Hospital Association appreciates prime sponsor's interest in ensuring hospitals are taking steps to screen, treat, train, and report on VTE. recently circulated a few questions about the bill with a clinical colleague of mine at the Foundation for Healthy Communities, and was made aware of existing CMS VTE quality measures. The VTE quality measures are designed to enforce evidence-based screening and treatment, which seems to align with the goals of SB 609. For hospitals to successfully meet the CMS measures, clinical staff receive VTE education and training on screening tools and best practices, and design their electronic health record systems with order sets, documentation templates, and clinical decision-making support tools to ensure compliance. Additionally, if a patient does not receive prophylaxis for VTE, a valid reason must be documented to comply with the CMS quality measures. I was hoping to bring my clinical colleague to the hearing to share her experience and knowledge with VTE screening and training, but she's unfortunately not available to join me this morning. She happens to also be the administrator for New Hampshire's Healthcare Quality and Patient Safety Commission. This commission was established in 2005 with the passage of HB 514, which enacted RSA 151G. The commission's charge is to review and analyze quality of care and patient safety issues, including but not limited to medical errors, unexpected adverse outcomes, and near misses in hospitals and freestanding ambulatory surgery centers, and to propose policy changes to improve healthcare in New Hampshire. Membership includes a representative from each hospital, each licensed ASC, and a designee from DHHS. RSA 151G7 requires the commission to submit an annual report on their work to, among others, the Health and Human Services Oversight Committee for accountability. The intention behind this bill seems to align nicely with New Hampshire's existing Health Care Quality Commission's charge, something I'm not sure exists in the state of Florida, where the language of this bill appears to have originated. Given the CMS quality measures and New Hampshire's existing Quality Commission structure, we question whether it's necessary for the legislature to embrace this model language from Florida, when it appears much of the intent could be addressed with our existing resources for quality and safety. Additionally, there are several technical challenges for our compliance with the bill and the proposed new registry that we'll want to expand upon if the committee wishes to move forward with this language. However, it's our recommendation that the committee move ITL or interim study to allow the Healthcare Quality and Patient Safety Commission to determine what additional guidelines and reporting, if any, would be appropriate in New Hampshire and whether statutory changes are necessary. Although we were not part of the drafting of SB 609, we welcome the chance to work with the committee and the prime sponsor. I hope this information is helpful, and I'm happy to answer any questions.
Sarah Yvard.
Thank you, and thank you for your testimony. So you're saying that there's existing policies that would deal with this particular issue, but we still have this particular issue. So how do we join those two together?
Right, so I would answer by saying this: hospitals have put significant time and effort and resources towards preventing preventable harm. And as much as they put into it and as concentrated as an effort as it is, there are occasions where tragedies happen, and it's very unfortunate. But we do have outlets in New Hampshire that provide the opportunity for clinicians to come together, to talk about those issues, to come up with standard of practice and proposals to try to address when those circumstances happen.
But isn't that what we're trying to do right now?
That appears to be the case, Senator, and I think my testimony is maybe there are outlets that exist in New Hampshire that don't exist, say, in Florida, where this bill was originated, that we could leverage instead of potentially putting more on the hospitals, the ASCs, and others that come at various potential unintended consequences. And I just want to make clear that I'm not trying to dismiss the importance of this issue, because it is very important and it's incredibly tragic when these events happen. All I'm trying to suggest is, what is the best mechanism for folks to come together, have better outcomes, work together, and make New Hampshire healthier because of it?
Senator Prentice.
Thank you, Chair Richard. Senator Avard's really gotten to the heart of what I was going to ask about, so thank you. Good.
I like the way you think.
So just getting into I know you provided a letter to the committee yesterday about the CMS activities, and I know in addition to having state requirements, there are federal requirements, and a lot of those things come from CMS because that's who pays your bills largely. So I don't know if you can expound a little bit on a little more detail on what CMS requires versus what the bill would require. How much uniformity is in that? You know, it would seem based on testimony that this is we were told it's a leading cause of postpartum death and serious events. So clearly it sounds like CMS has identified that as well, but what do they require and how does that relate to what we're talking about today?
Right, so CMS has, my understanding, and this is coming from my colleague that I spoke to, there are 2 clinical measures that CMS puts forward for their quality reporting. And that includes inpatient screening and ICU screening for VTE. And those 2 measures are applied to the quality metrics for hospital payment. So if a provider has an inpatient patient, if a patient is inpatient, their provider, with their participation in these metrics, has to screen the patient. And if there's no prophylactic provided, or a determination on no prophylactic, that has to be documented. And that's what CMS looks at to ensure they're in compliance with the measure for VTE screening. Okay. This bill, getting into the technicalities, would require training for all non-physician personnel in clinical facing or patient facing space, which is very extensive, and I'm not sure if that's totally necessary. I think there's some question on who's going to be required to participate in that. Secondly, there are several metrics that would have to be reported. Those, as I mentioned, with the CMS measures are integrated in the electronic health record so that when a provider goes through their review of a patient's case, they can check to make sure they've asked these questions, considered these potential unintended consequences, outcomes, and whatnot. And so that's all been integrated in their electronic medical record. This would appear to have to be integrated in some way into the electronic health record so that you could capture the data that's being required under the statute. So that's a little bit of a difference as well. I guess what I'm trying to suggest as well is this outlet through the Healthcare Quality and Patient Safety Commission that is made up of all hospitals. So in Florida, there are hundreds of hospitals. We have 26, right? So we're able to get together. We're able to use that venue to talk about it could be, an increase in sepsis and what to do, what are the best practices to address sepsis in a hospital. It could be, any number of things that group has said, we really want to make sure, we're seeing a rise in this, let's try to address that. Let's come together in an educational setting that's confidential, that they can share various cases and outcomes and try to address with best practices what's happening there. So again, I'm not trying to dismiss the bill. I'm just trying to suggest there may be other outlets for clinical personnel that are a part of this bill to discuss this and maybe make recommendations to the legislature in future years.
Okay, thank you. And the next question I have, you may not be able to answer it, but hopefully someone can follow up with us on that, is, looking at the CMS, you're inpatient and ICU, and I get it. We all know, anyone who's had a baby knows that you're in the hospital and then you're out of the hospital pretty quickly. So, and I think that's the case where here, as I understood from testimony, as they were in the hospital, CMS doesn't necessarily look at the day you leave and what you're going at afterwards. But given what we heard as far as how this is, I don't want to say common, but a leading cost of postpartum events, I would imagine, and this is where the question comes from, the standard of care would be consultation, advisory, look for this. If you get this, call us immediately. So I guess the question that I would have that you may or may not be able to answer, somebody could, what is the standard of care regarding postpartum observation for venous embolism?
I will have to get back to you.
All right.
I do know that the legislature has done a good job in years past of expanding the pre and postpartum.
That's where I'm getting at. We did a
Coverage.
Momnibus a year ago, and
Right.
I'm thinking this would fit in well with that.
Well, and because patients may be able to access those appointments and that care more frequently because of what the legislature passed, it's a means for that patient to come in, be looked over, reviewed, reaffirm what you might have heard in the hospital, offer them an opportunity to ask questions. So it's a great question. I think there's a lot of moving parts that have been very helpful that the legislature has done. I'm happy to look into what the standard of care is for a postpartum mother for VTE screening or recommendations.
That would be helpful. Thank you. Any other questions? Senator Prentice?
Thank you, Chair Rochford, and thank you for taking my question, Ben. So we've talked a lot about maternal mortality, which is, through Momnibus and other initiatives, this body has been really attentive to. So my question for you, though, is this applies to all patients, not just
That's right.
postpartum. Okay, that was number one. I want to just clarify that for the record. Number two, may I?
Yeah,
Is it
absolutely.
your position, because I'm looking at the Healthcare Quality and Patient Safety Commission and their purview, if I'm hearing you correctly, this commission, it's within their purview, and we could respectfully work with them and place this there to be continuously, like that the infrastructure exists. Is that your position?
I think that's a great venue, and they're accountable to those annual reports to ensure it gets, I think it's to the Senate President, the Governor, Speaker, House Oversight, and others. So I've talked to my colleague about that. If there was an opportunity to have a focus on VTE, would you, is that something that would be within your purview? She said, absolutely. That's a great idea, So I don't know that legislation is necessary to instruct them to do it. They would be held accountable, to make sure that they've done it if the committee or the Healthcare Oversight Committee saw that in their annual report.
Okay, thank you.
No further questions. Thank you very much.
Thanks, Senators.
Is there anyone else that would like to speak on Senate Bill 609? I was wondering if the department could come back up. I got a quick question for you.
Now you're in trouble.
This is going to be easy, John. So we just heard about 151 G7, the New Hampshire Healthcare Quality and Patient Safety Commission. Could you provide me with, and I've seen these before, but just an example of one of the past reports, just to understand what's in it, what they look at, and what they cover?
That is a great question. And actually, Mr. Bradley would have been in a much better position than myself. They actually, the group is administered and supported by an entity that's out there on Airport Road that is housed in the hospital, New Hampshire Hospital Association building. I can represent to you, because of my work with the Health and Human Services Oversight Committee, that they do a wonderful job with their annual report. You may recall, you typically will see those in late fall, or rather late summer, early fall, very robust. And so I would, okay, this is my fancy way of saying Ben Bradley, I think, is going to give you a much better question or response as to what they may be able to do. Miss Chris Kearing is I believe the executive director, so I think he'll be in a better position ourselves.
Great, thank you. And I just got put on that committee, so brand new, so I will be involved in that as we go forward. But I'd just like to see what it looks like. Thank you very much. All right, with that, I'm going to close the hearing on Senate Bill 609.
Review wants to know.
Yes.
What's the-
And I'm going to open the hearing on Senate Bill 452. Enabling healthcare providers to offer certain complementary and alternative healthcare services. And open the hearing and ask Senator Ward to introduce her bill.
Good morning, Mr. Chair and the members of the committee. I'm Senator Ruth Ward from Senate District 8, and I'm here today to introduce Senate Bill 452. And I'm doing that on behalf of a constituent. This bill will enable an individual to offer certain complementary and alternative healthcare services to patients, notwithstanding state licensing requirements, provided that the individual does not engage in certain conduct and the individual discloses their qualification and obtains informed consent from the patient for such services. Similar legislation has passed in Maine, Nevada, Colorado, New Mexico, Arizona, Louisiana, Rhode Island, California, Minnesota, and Idaho. Allowing certain complementary and alternative healthcare services increases the types of treatments that are available to patients while not compromising consumer protections. Through disclosure and transparency, patients are able to better understand the difference between licensed and unlicensed providers. I want to be clear that these types of practitioners would not be able to provide surgery, administer x-rays, set fractures, prescribe or dispense prescription drugs, manipulate joints or the spine, recommend an individual discontinue current medical treatment prescribed by a licensed healthcare practitioner, or indicate they are licensed with the state as a healthcare provider if they are not. To better align us with the model legislation that has passed in other states, Amendment 26-0630 would make a technical correction to the definition of complementary and alternative healthcare services. Thank you for taking the time to hear my testimony. And I am not going to answer very many questions because I have people behind me who know much more than I do about this issue. Thank you.
All right, Senator, thank you. I'm not going to ask if anyone has questions out of respect for your last statement. So we'll get them when we've got a number of people lined up to speak. So I'm sure we'll get to them. Thank you. Deanna Jurius.
Thank you, Mr. Chair, members of the committee, good morning. For the record, my name is Deanna Juris, Executive Director at OPLC. I did hear the senator reference amendment language that may alter the nature of my testimony and my concerns. Yeah, if I could see it quickly, that'd be great. I will speak while it's coming. I will speak just generally to say the office is not taking a position on the policy of this alternative health treatment, but I do have some concerns about the broadness of the language, even within the definition, which is why it's helpful here. I think the concern would be that people who hold licenses, right, they may be able to provide complementary or alternative services. And currently, if you provide a service outside of your scope of practice, that is a cause potential for discipline within your profession. And so I think this language might confuse some of that existing piece there, that a licensee either may evade discipline or that something alternative might be just considered not best practice. I don't think that's the intent of the bill, but I do think that's what the language in front of you could possibly imply. So I am concerned about some of those potentially unintended consequences. So I would respectfully ask if like some greater clarity or some narrowing of scope, if there are specific, practices, areas of practice, if there's even names, right? Like most professions have names. This is just anything you could possibly want to do, that some narrowing might allay some of those concerns. Right. I'm not sure that this current language provides much clarity. I think it might actually make it even broader. So that would be my concerns from the agency. Certainly happy to work with the committee on this and with staff attorneys within my office as well if you have questions or if you would like language to be reviewed to get closer to that intent, should the committee like to move forward with this policy.
Very good. I've got a couple questions, and then I'll open it up to the committee. So I know in your department, you certify and license a number of professions, a lot of professions, whether it be electricians, plumbers, respiratory therapists, nurses, pharmacists. And with all of those professions, there's a standard of practice. There's a minimum level of entry to do that, whether it be education, whether it be an apprenticeship, whether it be whatever it may be. How would you, again, being so broad, how would you see oversight mixing without any type of standard of practice?
I don't see this piece of legislation, the language as drafted, as creating any oversight. I don't see it creating any licenses. So I don't see it creating additional licensed professionals within the state. I don't see any credentialing. There's no rulemaking, no discipline. So what I see is basically trying to just, I'm not 100% clear on the intent, but what it seems to say is that some people can do some things that they define as complementary and alternative health without a license, period. And I'm not sure that this language provides clarity. I would say that might be the current state of play if the statute is silent on such things. So I think this to include it in a licensing scheme introduces confusion for licensed professionals, in my opinion. Because what's to prevent anybody licensed in a healthcare profession to say, nope, I wasn't being a nurse in this moment, I was doing this alternative care. So I think it muddies the waters because people could have multiple licenses, or we could have people that could have a massage, physical therapy, massage and nursing, doula. There are a lot of ways, but then you would have very limited scope of practice. So I don't see this as introducing any regulation that is enforceable by my office.
I guess my follow-up to that would be somebody goes and gets training in homeopathy.
Mm-hmm.
What's stopping them from using that training in New Hampshire now? They're not prohibited from doing that. So would this provide any sort of delineation or protection or anything else?
I don't see anything in the language that creates more protection. I think it creates confusion for licensed individuals.
Okay, thank you. Are there any questions from the committee?
Senator
Abar.
Yeah, so basically, if this goes forward, there's no credentialing and there's no rulemaking that you can, right? And the dumb question, what is homeopathy? I have no idea what it is.
It's actually an ancient standard of care where you use like very small amounts of ingredients to stimulate the body to respond to get a response.
Like
So,
vitamins?
like arnica. You ever heard of arnica for treatment?
I'm losing it,
Anyway,
so-
well, we can talk about it offline. Yeah.
Thank you.
Thank you.
Any other questions? Senator Prentice.
Thank you, Chair Rushford. Is there thank you for taking my question. Is there I'm trying to develop a list of who this may or may not apply to. And, I can think of businesses, where that have, like if you go to a spa, their massage therapists are licensed, but you won't be advertised, another alternative treatment that doesn't require licensure. Is that where we're going with this?
I'm going to throw out a few what I might even consider proprietary names that I'm unclear on, but some kind of Ayurveda, Reiki, healing, the homeopathy, that type. My thought is this could possibly be what this is getting at. I'm not seeing any of that in the language, so I guess that's why I'm before you. And quite frankly, this didn't originally flag out on any of my searches because it doesn't have to do with any licensed professions in my office. So when we do a scan through to see what do we need to keep track of, this came very late to the game because of its lack of referencing to any licensed professions. So again, I'm sure there are people behind me that may have a better understanding of the intent of the language, but I'm not seeing that on the page.
Follow up, Senator?
Thank you. Just quickly, so there's a section of this that applies to transparency, and consent, so people understand like that there's a difference between like who's licensed and who's not licensed from a consumer side. Could that be enacted without any type of requiring any type of licensure? And I don't exactly know how it would be, but I think there's a consumer value. I'm just, again, looking for a list to follow. So I wanted to highlight that. Yeah.
I appreciate the comment. I don't see any enforcement mechanism. It would seem that there would be a civil remedy, so that would be within the courts. It would not be within the OPLC. Yes.
All right, Senator Long, I saw your hand up.
Yeah, thank you, Mr. Chairman. Thank you for your testimony. Am I assuming correctly that your major concern is licensed people crossing over into another licensed jurisdiction? Is that your major concern?
I think the concern is every profession that is licensed has a narrow scope of practice. They have codes of ethics in which they have to stay within the bounds of. If they step outside those bounds, that can be cause for discipline by a licensing board or a licensing entity within the state. So the concern is that folks that are licensed that have that box, this may open a kind of an open a way through. And again, I don't think that was the intent of the bill, but I think that is what the words say is someone potentially could say this is an alternative health care, but it could potentially be a practice that was discontinued as not national standards 50 years ago. So I think that's my concern. Then it would muddy the waters. I don't know what that discipline or how effective the enforcement of those codes and scopes of practice would be. So yes, and then some.
Right. Thank you.
Yep.
Any further questions of the committee? Thank you, Director.
Thank you.
Aubrey Friedman.
Mr. Chairman, committee members, Aubrey Friedman, I live in Bridgewater. I speak in support of this bill. Americans aren't exactly known for being particularly healthy. So this bill would add more options for consumers. Number one, just because I think it'll bring more people, will be willing to provide health care if they don't have to worry about getting in trouble with the licensing laws and so forth. It's basically a safe harbor law. Secondly, this has nothing to do with safety. It specifically, as the senator had mentioned, has no surgery, x-rays, prescribing medicine and so forth. So those will remain licensed as they are. That's not changing. These are, and it's been, I myself was wondering what it was when I researched this bill. I come up with herbalists, traditional naturopaths, energy healers, wellness consultants, homeopaths, and body workers. That's my interpretation. They're not specifically, these are things that could help people improve their health. That's a good thing. More options are a good thing. So that's my main point. And again, the informed consent is also it's pretty clear there's a lot of things you have to do here to make sure that the consumer knows that they are not that the healthcare provider is not licensed by the state, and there's disclosures and everything. So I think that part is pretty clear that there's no way the consumer wouldn't know. And then lastly, I think the healthcare system is overburdened right now, particularly in rural. And if you have to change doctors, you have to get an appointment, you have to wait for months. This would help to lessen the burden. If people have a health concern, they can seek another avenue. That would be a good thing. And there would be more people available to do this if they don't have to worry about getting in trouble with the licensing people, and still retains the right to sue if there's actual harm or negligence or anything like that. So basically, more options are a good thing as far as I'm concerned for consumers, and that's why I support the bill.
Great, thank you. Are there any questions? Thank you very much.
Thank you.
Let's see, Julie Boris. Chair calls Julie Boris.
Good morning.
Morning.
Good morning, Mr. Chairman and members of the Health and Human Services Committee. My name is Julie Boris. I work with National Health Freedom Action. We're a 501c4 nonprofit organization established 25 years ago in 2001. We work to protect maximum healthcare options for consumers so they can access the practitioners, products, services, and information that resonate with their personal decisions on achieving and maintaining health and wellness. Thank you for hearing SB 452 today and for the opportunity to speak in favor of this important bill and Senator Ward's amendment. We are so grateful to Senator Ward for introducing this bill. Our organization has been in touch with New Hampshire residents who want this bill. They want to provide a safe harbor for complementary and alternative healthcare practitioners who do not have conventional medical or health profession licenses, such as herbalists, homeopaths, and there are many other modalities. The bill would protect consumer access to these practitioners and set out clear expectations for unlicensed practitioners, including a list of prohibited acts and disclosure requirements. This bill would allow complementary and alternative practitioners to practice without the worry of being charged with practicing medicine or other healthcare professions without a license, as long as they follow the bill's common sense guidelines. Our organization works with many states on protecting access to complementary and alternative practitioners. We often help address a key problem. In most states, the legal definitions in healthcare profession acts are very broad, sometimes covering all forms of healing. Under these definitions, anyone acting within that broad scope without a license, even when not dangerous or harmful, can be criminally charged or fined thousands of dollars. SB 452 does not change current health care profession acts or their legal definitions. Rather, it provides an exemption to professional licensing requirement acts for unlicensed complementary and alternative practitioners, so they will not be accused of unlicensed practice if they follow the bill's guidelines, avoid prohibited acts, and provide required disclosures, including credentials. If they act outside the safe harbor, they are not exempt, and current laws apply. A practitioner exemption law will protect the broad domain of complementary and alternative healing modalities practiced in New Hampshire that do not rise to the level of potential harm requiring state regulation. And it adds transparency and consumer protections not already required. 11 states have passed such laws, including neighboring Maine in 2019. Consumers want to use gentle healing therapies alongside conventional pharmaceutical options and want access to practitioners who can help them navigate holistic health choices. Finding a practitioner who can discuss these approaches is challenging because they work in a vulnerable legal environment. NHFA, National Health Freedom Action, respectfully asks you to support SB 452, and we are happy to answer any questions. Thank you for your time.
Thank you. Are there any questions? Senator Long?
Thank you, Mr. Chairman. So in your opinion, do you feel that this would be beneficial for those that aren't licensed? Or do you see more people with licenses practicing
For those practices that are unlicensed.
unlicensed? Okay, thank you.
So do you envision a scenario where you may have a licensed professional in one modality? They have a license for dentistry, but they want to do something else that isn't a licensed profession. Would there be opportunity for them to do both things? One using their license and one using going off?
Did you say dentistry? As an
Dentistry, I
example?
just use dentistry as an example.
I might have to refer that to the lawyers on our team. I would assume if you were credentialed to be something else, if you studied, for example, homeopathy or herbalism, that you could practice that, but I would prefer to, if I could get back to you to answer that specifically from what the attorneys might say. There are, in the bill itself, there are the exclusions on the very bottom paragraph that I think address that. Scope of practice. This chapter shall not affect the scope of practice of a healthcare professional licensed under this title or their right to practice complementary alternative healthcare. So it's not addressing, I believe, those.
Okay. And then my follow-up would be along the same lines as I asked the director. We have a number of professions that are licensed in this state, and we license them because there is a standard. Dentistry, for instance, and they have to go to school for a long time, and they have to pass a board exam, and the state oversees their practice in the name of patient safety. But what's to say going the other direction? As long as we have informed consent, they don't have to be graduate from a dental school. We don't have to have take a national board exam. As long as they're informed, the patients are informed, we can disregard any standards that are out there. So I worry that because there isn't a lot of definition on who this applies to, anybody could hang a shingle saying anything, I'm going to do air therapy, and we can we now can and as long as there's informed consent, they can collect a fee and breathe air.
I think the goal of the bill is to protect some ancient and long time holistic healing therapies that have been around and are not harmful. They don't rise to the level of needing licensure because they're not causing harm. So that's where this bill is trying to protect. And these, again, some of these have been around forever. Some of these, like you could even include, I believe, meditation, aromatherapy. I know some of the big ones. And there are people here today to talk that are practitioners here in New Hampshire, some of these unlicensed practitioners. So I think to hear from them would be, probably the best way to address some of these questions.
Great.
And again, if there's any specific question I'm not answering, we do have attorneys. I'm sure they're listening right now. And they would be happy to answer the specific questions that you've asked
Great. Thank you very much. Are there any further questions of the committee? Thank you very much.
Okay, thank you.
All right. The chair calls Jesse Mulligan.
Hello.
Good morning.
Well, I want to start off by saying thank you for the opportunity today to speak in support of SB 452. Okay. My name is Jesse Mulligan. I'm an herbalist working at an herbal apothecary here in New Hampshire. I come to this work with both lived experience and a scientific background. My mother is a professor at UNH and raised me to be a prestigious and capable asset to the community. I have also backpacked through 5 continents by myself, observing the various approaches to healing around the world. I hold 2 college degrees, biochemistry and molecular cellular biology, and a Bachelor of Science in psychology. I worked on preclinical research studies assessing the neurobiology of addiction with Dr. Sergios Chartikov at the University of New Hampshire. I learned the dominant models, neurotransmitters, reward pathways, pharmaceutical interventions, and more. I studied biochemistry not to move away from the natural world, but to better understand it. How plants, humans, and systems interact at the molecular level. During college, I found myself largely unsupported. There was no guidance for integrating my scientific background with a holistic or preventative approaches, unless I was willing to pursue a PhD or an MD and stay within a more traditional path. I took time contemplating my options, ensuring that whatever career I choose was to be of utmost benefit to humanity. After university, I chose to follow my heart and take the herbal path. Studying herbalism has been, for me, a process of connecting the language of biochemistry and molecular biology to the patterns we experience in the natural world, with a goal to better articulate the practice of balancing mind, body, and spirit. This was the goal that I set out to achieve during my college years, and it is an honor to pursue this mission as a career here at New Hampshire.
Doing well.
Pardon me.
You can relax.
Yeah, not used to this. First time. Okay.
Us too.
Maybe a little valerian root would help you out.
Those dreams, though, those dreams be crazy. Okay, so today, as an herbalist, I do not diagnose disease. I do not replace licensed medical care. I work transparently, within clear boundaries, and with informed consent. Informed consent. The Safe Harbor Bill allows individuals like me to practice without legal ambiguity. I am here today in support of the Safe Harbor Bill because it directly impacts my work and my ability to serve the community ethically and transparently as an herbalist. SB 452 sets clear boundaries, and it requires honest disclosure. It respects the role of licensed medical professionals while also recognizing that health is dynamic and not one size fits all. This bill does not undermine public safety. It strengthens it. It brings alternative wellness practices into the light, where disclosure, accountability, and honesty can exist. It respects adults' right to make informed choices about their own bodies, while preserving the role of licensed medical professionals. For me, this bill is not abstract. It directly affects my work, my livelihood, and my ability to serve my community responsibly. I urge you to support the Safe Harbor Bill and uphold New Hampshire's values of individual liberty, transparency, and informed choice. Thank you for your time and consideration.
Thank you. So I've got a quick question, then I'll open it up to the committee. This bill 452 was signed into law today. How would your practice change?
I would be able to operate without fear of legal ambiguity. So I would be able to operate.
So what in your role is ambiguous that you do? Why would there be any question if, you know, I mean, you gave a good point of how you're qualified. You've got a tremendous amount of background. You don't prescribe, you don't diagnose.
Right.
So where's the ambiguity in what we're doing in today, in February of 2026?
When it comes to making advice regarding people's livelihood and their wellness, they often look for licensing or some sort of board exam, you know, something that has systemically gave them the right to practice. Because of my vast experience traveling around the world, having different, you know, pockets of education, there's no licensing for what I provide. And what I provide is largely advice. It's not surgeries. It's not directly manipulating the body. It's just advice and support for people who have been otherwise wronged by the avenue of medical practice they chose to take. How does this affect me in my day-to-day? It gives me confidence to provide the care that people seek and that is in high demand.
So are you saying there should be licensing?
No, I'm saying that there cannot be licensing for the work that is so vast, that is derived from indigenous cultures around the world. That's herbalism, that's Reiki, that's energy. There's no licensing that can catch all of it. And so what we do is we fully disclose our work and what our experience is, what our background is, what our education is, and then it's the adults that can decide if they want to rely on that. This bill provides us confidence to do that.
Last question for me, then I'll open it up. So I have a license,
Okay?
and I consult people in the past on herbal therapy, homeopathy, lifestyle changes. If I make a mistake and that person gets hurt, I lose my license.
Mm-hmm.
Why should I have a license that can be lost and my career goes down the tubes and other people don't have that?
Because some people choose to follow their heart.
Thank you.
Mm-hmm.
Any questions from the committee? All right, thanks for coming in.
Thank you kindly.
Leslie Joes, all right. I didn't see the accent mark, so I didn't say Jose, so.
Thank you. So thank you, Chairman, and the committee for hearing this bill and bringing it forth. My name is Leslie Jose, and I'm speaking on behalf of myself as a consumer and also my business, as well as other practitioners. And before I read what I had prepared, I'd like to bring awareness to language. And I think across the board, we get patterned into using language that isn't clear, and it falls into presumptions. So the practices that are being affected by this, to me, are not healthcare practices, they're wellness practices. Practices that are within the medical system have the need for licensing. They have the need for that in-depth oversight and security. These practices are breathing. They're non-invasive. They're about supporting someone's wellness. And okay, even for me right now, I'm nervous. So if I settle my bottom, I put my feet on the ground, I take some breath. That's what so many of these practices are offering. And it's not a licensure that's needed to allow someone in that place. So for me, before I go to this, I wanted to speak to language. I think wellness services, wellness providers, as well as dropping alternative. There's nothing alternative about these practices. They're complementary to a person's well-being. They're complementary to whatever that person is accessing through licensed people. So to me, creating that clarity is going to ease the pathway for where we go to not only provide options for our citizens, but also the hundreds of people that are doing a practice for themselves as well in a business way. So
I'm gonna stop you there for a minute.
Mhm.
We can all read, so tell us what it says in your own words, and then you can hand that to Sophie, and we want to hear from you, from your heart.
Yeah, well, my age brain has
All
a
right,
tendency
well,
to send me way off. So
I wouldn't
I'll
wouldn't have judged your age.
I'll
from
use
looking
this
at
to
you, but-
guide myself. So I am a Reiki and sound practitioner. I reside in North Sandwich, New Hampshire, and my practice is in Moulton Borough. And I'm here in support, obviously, of SB 452 as it's been amended. Freedom of choice in health and wellness care stands among our most personal and cherished liberties. I'm going to say it again. Freedom of choice in health and our wellness care stands among our most personal and cherished liberties. There's a Pew Research document way back in 2016 that indicated that 49% of Americans utilize complementary, and in the language it says alternative healthcare options. The use of these options has clearly increased since that time. And in that research, it also stated that consumers back then spent $30 billion annually out of pocket on complementary products and services. Not only do the practitioners need protection by the passage of this bill, but the consumers need these services protected for them to be able to access these services. And I've been in practice for more than 20 years. The professional and respected offerings in my practice have brought comfort, relaxation, and hope to hundreds of clients. Passage of this bill will support the continuation of not only my livelihood, but also the services the public wants. This bill provides a win-win, I believe, for the state of New Hampshire and its citizens. It's important for the secure continuation of my practice that this bill passes. The years of study, the relationships established with other professionals for recommendations that go in both directions for the well-being of our clients, the cost involved with enhancing a business to support continued quality experiences for clients, and the established financial commitment around my practice, well, these need protection through this bill. And clients deserve the comfort and care provided by these services. The practices are important, I believe, are an important link in the cog of wellness for individuals in the state of New Hampshire. They do not and should not replace important access to our medical systems. The practices support calm, they support choice, they support the frazzled time and needs between doctor appointments and procedures. They enhance a person's sense of agency and well-being. They often enhance the outcomes of mainstream medicine and are supported by many of those professionals. We often hear the language, I need to get the stress out of my life. We can't. Stress is there. Stress is, our lives are full of stress. Stress is not the problem. The effect of stress is. And these practices support releasing the effects of those stressors. And as stress in our lives increases, supporting easy access to holistic, non-invasive practitioners keeps the residents healthy, and I believe in every state encourages us to support a safe harbor bill like this. So please, I encourage you all to consider a positive vote, and I really thank everybody's efforts in trying to come up with clear language around any confusions that are here, because that's going to be a positive for everyone.
Great. Thank you. Are there any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. Like Ms. Mulligan said, she already has informed consent currently. Do you also have that currently?
Yes, I do not know any practitioners, and I know lots, that do not have disclosure about what their practice is, who they studied with, or how long they've been doing it, and also that it does not replace medical care, that it encourages everyone to be sure that they are taking care of their medical care. And very often it's things rise up in a practice that there is the suggestion of, you just raised a concern or an awareness, and you probably should take that to your PCP. So it's again, that link in the cog where there are people who are comfortable and give agency to their voice and discomforts in a non-invasive, safe practice that might not be able to get to their doctor. So it gets that nudge to go. This is, it's not, there's no judging, there's no assessing, there's no diagnosing. It's, if I put my hands on your back and ask you to breathe, or even not on your back and ask you to breathe, it allows the body to calm so it can be clear about the choices that it makes.
Follow up, if I may?
Yes,
Mr. Chairman. So have you, in the 20 years that you've been practicing, have you determined that something you were doing for somebody may not be the best practice right now? Or, well,
There's no harm in being a part of life's energy. The movement of life is here for us. I look hard at assessing my own presentation. Any of the modalities that I've been a part of, there's a listing of criteria, what you follow, what's out, anything out of this is out of scope. There's no diagnosing or, oh, gee, I think you have none of that is within the scope of that.
Okay.
And I feel as though the questions that rose up earlier about if it's a dentist or a nurse or someone who's wanting to do a practice, those professions are guided by their own rules, by their own oversight. It doesn't, if they want to include a practice, they need to go to their supervising body about how to implement. I don't think the bill is addressing that. That's within their profession to figure out how they bring this. This is removing a threat of licensure and expense and removing access to the public about practices that don't need to be licensed. I wish I had a better example of that, and I'm happy to
thank you.
offer more. So, yeah.
Senator Ibarra.
Yes, and thank you for your testimony. Trying to get a beat on this a little better, but so trying to alleviate the fear, right? There's a fear.
Pardon me?
Trying to alleviate the fear of maybe somebody coming after somebody for malpractice. Is that what this is going to protect?
No, for me, I don't go to fear. I go to access.
Okay.
That if this moves into some sort of licensure, and that most people who are offering these kinds of non-invasive, safe practices, they don't have the financing to, and it's not necessary. There's no movement of tissue, say, for a Reiki practitioner to become a massage therapist. The expense of that, the cost to keep that license up, the timing and all of that. There's nothing underneath what's happening that needs a license. I'm sorry.
Yeah. No, I'm trying to, we're having a conversation here right now,
Yeah.
if I may.
Absolutely.
Yeah. So.
Yeah.
Right now, are there instances that you know of, because this bill is not enacted, where people have either gone out of business or have had negative impacts done to them because of their practices that you do at this point?
I don't know of anything that's come forth. If somebody's sitting in my treatment space and I'm sounding singing bowls and bells, there's no harm. Before they come in, as you said, the disclosures and, do you have any aversion to sound? And it's not loud, it's not, so to my knowledge, there's not been anything that could possibly have gone to a legal thing. People who are stepping out of, appropriate action, that's written within the bill. I mean, it's not appropriate to, say, touch someone in their private parts. I mean, that's across the board, that's.
Thank you.
I just want to follow up on something you said. So how is today's state of government, intrusion, less intrusion, getting in the way of sounding bowls and bells? I mean, is there anything getting in the way of you doing that today?
I think what's in the way is the instability of what's going to happen. If there isn't a bill established that secures with clear distinction of what is there, then what's to move it towards saying, okay, you're a Reiki practitioner now, we don't have any place to put you, so you're going to have to go be a massage therapist. And so to me, that's the security of having a bill that safeguards the practices that are being provided that don't they really aren't qualified to be within a license. There's no moving of tissue, there's none of that. So to me, that's the bill, is it creates a clear foundation where these businesses are established without the risk of being then told you can't practice unless you go to chiropractic school, where how is, that's, I don't have a concern over the legal piece. That's not I see that that's in the bill. And for me personally, I don't see that that's a concern for me. The concern more is then being told that we have to be licensed. That's not.
So with this bill in place, would you then be able to grow your practice because there would be an implied therapeutic value for what you're doing?
I'm trying to interpret your question so I can be articulate in my answer. I'm not sure.
So is there, we talk about herbalism and Ayurvedic and breathing techniques. And, I think a lot of us are trying to get to why we need the bill to be able to do those things. And I guess, does this validate, if this bill were passed into law, does this validate or give any claim of efficacy or therapeutic outcome?
Thank you.
In the guise of, we're gonna have, informed consent,
Yeah,
so,
yeah.
but
Yeah,
then
thank
we
you
can
for the
kind of put
clarity.
this.
Yeah. I think that what it offers is the stability that where I am is where I am. And I don't have to worry about having that get swept out from underneath me with the now I have to become a massage therapist to practice what I practice.
All right.
There's nothing in the language of this that says this gives me permission to do more than what I do. There's guidelines and within a scope that's within all of these practices. And people who step in to offer these kind of wellness practices, the integrity of their being are ones that stay there. The stuff that steps out of scope, we have laws around all of that anyway. This, I think, secures people that they're going to have the practice that they have. And it allows then the public to continue the varied access. If it were to go into a licensure scene, then it really shrinks down what becomes available. When you lose a lot of people that are already doing it, there's varieties of strains. If I'm going to get, I'll use the herbalists, that if there's mint, we say the word mint, there's so many different kinds of mint. So if you go to a licensing situation, you're going to lose some of the quality and the diversity that's there.
Okay, thank you. Senator Abard.
Okay, so I'm gonna let me go what's going through my mind, which is very small. So I have a little, with my filter, I'm processing this, and I also know, so I'm a co-sponsor on this bill. So in spirit, I'm with you. But I have to look at this as though, okay, so if we pass this bill, then it goes to rules. They have to make rules. And when I'm hearing from testimony, whether it's from someone who's done extensive global learning on this particular versus whatever you're doing, OPLC has to make rules. And they testified, they don't know where to begin, and how do you make the rules, and then who's going to enforce these rules, not to invade what you're doing. And so that's what's going through my head. How is this going to work? Because you're asking the state to get involved and to make rules, but that's what a law does. It makes rules, and then the executive branch enforces those rules as we legislate them. How are they going to enforce this?
Yeah. So being a bit naive in the legislative side of stuff and how those pieces come together, again, I think language is huge. And having alternative makes it confusing. People are choosing this instead of, no, it's complementary. So having this bill go forth to me, allows more clarity and information to the public who are already choosing this. It's huge. I mean, the economic piece alone is enormous. If it was 49% from that research thing that the Pew did in 2016, I mean, the amount of people who access the support, the complementary pieces that are there. So a bill that frames these kinds of practices, to me, creates that clarity. It creates the security for the practitioners that they are within a frame. They know what the frame is. And they know it already because it's how all that I'm aware of are practicing. But I think that secures it. And then it also continues to have access for our citizens. So to me, it's a win-win for the state of New Hampshire as well as the citizens.
Any further questions? Senator Long?
Thank you, Mr. Chairman. Yeah, no, this was, I'm wondering if you know the percentage of service that you provide to customers that have a license that they're already being looked over with a licensed person. They're just going to try some alternatives.
So if I'm interpreting your question, you're asking of my clients, the percentage of my clients that are seeing me as well as
A licensed professional,
all
the same.
I mean,
So-
well, let me answer to be clear. So if I can clear up your question, none of it is instead of anybody's personal choices. Within sort of the client information thing, it asks if they have a PCP. Most everybody does, but lots of people don't. That informs me that if somebody says no, and I can offer direction to here's a primary care profession in Plymouth that might be able to support you having care. None of what I'm doing is in place of that. So if I understood your question, it was how many are in the practice that also have licensed people taking care of them? Most all of us do. We have whatever it is, and that's their, yeah.
Very good. Thank you.
I'm sorry if I babbled too much.
Any further questions? Thank you very much. Is
Thank
there
you all.
Anyone else that would like to speak on Senate Bill 452? With that, I'm closing the hearing. So I'm going to open the hearing on Senate Bill 498. And I will ask Senator Birdsall to introduce her bill.
Just press your button when you're ready.
Thank you, Mr. Chair. Thank you, committee. For the record, my name is Regina Birdsall, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. I am the prime sponsor of Senate Bill 498. As I just said, it's deja vu all over again. This is a bill that I think is very important. It involves the Fast Forward program that we have. It establishes New Hampshire's Children's Behavioral Health Association for the purpose of collecting assessments from the insurance carriers so that we can, for payments, so that the services that are covered currently by the state can be covered under these assessments and paid for through these assessments. Currently, my understanding is over to every biennium, the state is paying about $2 million for the portion of the Fast Forward program in instances where it's just a few children that are actually have insurance coverage, but there are services under the insurance providers that are not covered. So the state has to come in and purchase, or I talked to the Department of Insurance this morning on the way in. I know that it's a long process. They are working on an amendment between the providers and the CMEs. And I would ask that we get a little bit of time to get this moving, because we know that if it goes to the House without some support, we are going to run into House Commerce Chair, who we know what happens every year in House Commerce. So I ask you to give us some leeway so that we can try and get something through, an amendment, and if not, we'll go ahead and put this through and fight with House Commerce again.
Okay, thank you, Senator. Are there any questions? No, thank you very much. So we're going to hear from the departments, and then we've got a lot of people speaking. So after we hear from DHHS, will be a 3-minute timer that Sophie will be running for us. So those that are coming to speak, if you're just here to read something, we can all read. Feel free to just drop it off and with our committee staff, and they'll circulate it to us. And again, if we'd rather have you not read off a statement, summarize it in your own words, and we can make the most of our time here. So with that, the chair is going to call the New Hampshire Insurance Department. Jennifer and Keith.
Hi, good morning, Chairman Rochford and members of the committee. For the record, I'm Jennifer Smith. I'm the Legislative Director for the New Hampshire Insurance Department, and I'm joined this morning by our Deputy Commissioner Keith Nyhan, Commissioner Betancourt, and our Director of Life and Health, Michelle Heaton, who would normally be here. They are both traveling on state business today, so they could not be here. But our Deputy Commissioner has a statement from the Commissioner that's being circulated to you now. I think it's important. It kind of sets the tone as to where we've been on this. So he'll read that through to you quickly. And then I am here if there are any questions in terms of what the department's involvement has been, what amendments we've been working on, discussions with the stakeholders, et cetera. So we'll be happy to answer those questions or provide information to the committee.
Thank you very much. Again, with your permission, we are going to read Commissioner Betancourt's statement into the record. Thank you for the opportunity to provide comments on Senate Bill 498. I regret that I am unable to appear before you in person today due to previous scheduled business. I want to begin by expressing my strong and clear support for the underlying objectives of this legislation. Expanding access to effective community-based behavioral health services for children and families is both sound public policy and a practical necessity. Early intervention and coordinated care models can improve outcomes, reduce system strain, and provide meaningful stability for families facing complex challenges. These goals are important and deserve careful legislative attention. The Insurance Department has long recognized that mental health is essential health. I remain fully committed to working collaboratively with our colleagues at the Department of Health and Human Services and with the legislature to advance sustainable, legally durable solutions that strengthen New Hampshire's behavioral health system. I also want to address a matter that significantly informs my perspective on this bill. The current structural and financing arrangements under which this program operates is placing strain on the DHHS Medicaid budget. This is not abstract. This is not an abstract policy concern. It is a fiscal and operational challenge for the state. I view remediation of this pressure as a priority and consider it part of my responsibility as Insurance Commissioner to be a constructive, engaged partner in identifying solutions. The insurance department stands ready to devote the necessary regulatory, actuarial, and policy resources to assist DHHS and the legislature in addressing these cost dynamics. Whether through market-based adjustments, programmatic refinements, or alternative financing structures, I am committed to doing everything within the department's authority to help stabilize the existing framework and reduce unintended budgetary consequences. Collaboration in this area is not merely desirable, it is essential. At the same time, I believe it is appropriate to candidly acknowledge one area of policy tension within Senate Bill 498. The assessment mechanism proposed in the bill is far from my preferred approach to program financing. As a general matter, I have consistently expressed caution and concern regarding assessments imposed on commercial insurers, as such mechanisms ultimately flow through insurance markets and may cause secondary implications for consumer premiums and cost transparency. That said, this proposal contains features that distinguish it from other assessment constructs previously considered. Most notably, it includes a defined and tightly controlled aggregate cost cap. The state's fiscal exposure is therefore constrained and predictable rather than open-ended. From a regulatory and market stability standpoint, that design element is a notable improvement. Although the assessment mechanism is not a policy tool I favor, the concern is not a basis for the department to oppose this legislation at this stage. The underlying policy objectives are significant, the fiscal parameters are defined, and the legislature is the proper forum for weighing the competing considerations. Accordingly, the department does not oppose the bill's continued consideration and refinement as the legislative process moves forward. I also respectfully note that alternative approaches were explored, including proposals developed by the insurance department that sought to mitigate a significant portion of the identified budget pressures without the reliance on an assessment mechanism. While those concepts were not incorporated into the present version of the bill, they remain viable and from a regulatory and actuarial perspective. We look forward to continuing to support the legislature as a collaborative partner and resource as deliberations progress. I fully understand the practical considerations affecting those alternatives, particularly given the participating carriers and certain behavioral health providers have not yet finalized on agreement on key contractual terms. However, discussions among those parties are ongoing, and it is my assessment that negotiations are proceeding in good faith, albeit at the measured pace typical of a complex reimbursement and network matters. Should the assessment structure emerge as a barrier to passage or implementation, the insurance department stands ready to work with legislators and stakeholders to evaluate adjustments or alternative mechanisms that preserve the program's core objectives while addressing market and policy concerns. My intention is not to impede progress, but to help ensure that the ultimate framework is stable, transparent, legislatively viable, and fiscally responsible. Thank you for your time, your careful consideration of this legislation, and your continued commitment to improving behavioral health outcomes for New Hampshire's children and families. Respectfully submitted, Commissioner Betancourt. And on that, we're happy to answer any questions that we are able for you. And I know there's others here to provide testimony on both sides.
Thank you for your testimony. Questions from the committee? Senator Bertel, it's your bill, so I'll let you go first, and then Senator Prentice.
As we spoke this morning, Jennifer, can you kind of give us an update on what's transpired with a potential language or amendment?
Sure, happy to. Starting back when Senator Bertel decided she was going to refile this bill in the fall, we've been having conversations with both she, some of the staff, Department of Health and Human Services, and we kind of started there first to look at the bill to see, can we operationalize kind of what is in the bill? How would we do that? What are maybe some technical challenges? And what are maybe some alternative options? So the department put together an amendment that's still kind of really being fine-tuned, and it's what Senator Bertel spoke to, that would move away from the assessment, but would try to move the CMEs toward billing commercial insurance as any normal provider would. Being cognizant of that, what the amendment tries to do, we're very aware of the concerns from the stakeholders and the department to not unbundle this group of services, because that is where they're really getting their impact. So in our amendment that we're putting forward, what we're trying to do is not unbundle the services. We want those to continue seamlessly for those kiddos, so they're getting the full benefit of that. But we want to, on the back end, unbundle the payment so that what can be billed to commercial insurance gets billed to commercial insurance by the CMEs. They get reimbursed for that. And the proposal that we've been working back and forth from is that most of the providers are not in network with our insurance carriers. So they would be reimbursed at the qualified payment amount, which is normally higher than your out-of-network reimbursement rate. So the amendment would require that if these providers cannot come in network with an insurance carrier and get an in-network rate, that they would then be reimbursed the qualified payment amount, which again would be typically higher than the out-of-network rate. And then at the same time, by doing this, it helps bridge a gap for us on the insurance side of things where we have no claims data really to know what the cost of these services are for these kiddos. So we can get some claims information for the services that they can bill and that are traditionally covered through commercial insurance. And if there are parts of the bundle of service that normally would not be covered, the state can then continue to maybe fund that small set of services that is not covered, but we'll have a far better understanding of what the actual cost is. So what is the true delta between what commercial insurance will pay and what is not paid that, but is really an essential service for these kiddos. And then that would give a much truer picture in terms of if the state wants to come in and still cover that cost to keep the integrity of the program together. It's much more in line than just, an assessment might be over what is needed after insurance has come in and paid that piece. So that was the general premise of the amendment. There are other components of it too, understanding that our CMEs have typically not worked with, because of the types of services they provide, a lot of them don't bill insurance. They work a lot with our Medicaid community as is, so that's a separate arrangement that the insurance department is not involved with. For Medicaid, we don't regulate Medicaid, but there's might be a bit of a gap that needs to be covered here to help these CMEs get online with billing, training up some staff. So we even thought that there might be an opportunity to try to seek out some grant funds to help the CMEs so that there's not a cost burden to them, but folks can come in and get them up and running to be able to bill seamlessly with the carriers. So that's kind of the general process of the amendment. What we spoke to, Michelle can definitely speak to the technicalities of it better than I am, being an attorney. But that's the premise that we were talking with the group about. And as we were having several of these conversations, it became clear we kind of were trying to hone into what's the number of kiddos that we're talking about that have this commercial coverage that actually are utilizing these services. And it's a small enough amount where the carriers then said, well, can we maybe get the providers in network? So we took a little bit of a pause from working the amendment forward to allow the carriers and the CMEs to start some conversations to see could they get in network. So that's where we've been for several weeks now. The bill, was filed and introduced, understanding that we kind of had this alternative consideration with the amendment the department put together, but that also the carriers and the providers were working on their own to see is a legislative solution maybe not necessary if they can come into network. And then if that is able to be achieved, the bill can maybe be further amended, as we suggested, to just bridge that gap of the services that are not being covered.
Senator Prentice?
Thank you, Senator Abard. And Jennifer and Keith, good to see you. And super complicated. Thank you for unwinding that amendment. I'm going to work this backwards because you talked about network adequacy. You talked about being in network, and that takes me to network adequacy. So it's my understanding the carriers are supposed to have network adequacy with certain behavioral mental health services. Is that true? Are we there?
Yes, that is true. All of our carriers do meet network adequacy requirements, Senator. So, but not all providers are in. I'm sorry, I apologize. But not all of the providers choose to be in network or are in network. So this is really an effort to bring those CMEs into network with the carriers.
Okay, so follow up.
Yes.
So what do we do now if so you're saying there is network adequacy, is that throughout the state? And if a provider isn't in network, what do we do? It's taking me back to the ambulance discussion, so I'm just trying to align this, okay?
Yes, I think if I'm understanding where you're going on this, so these guys are not in network. So for the way we've drafted the amendment, by setting them up under this QPA, it's a little bit similar to kind of, I think, what maybe where you're trying to connect these things with the rate that we set forward for the ambulance provider. It's giving them an alternate route to see if they, to kind of solidify that we recognize the validity of this program and the services that these kiddos are doing. We want to give them a bit of a more of a rate than what they would get being out of network. And when we say in network, out of network, I think you all know that that's not so much meaning that there's not a network, an adequate network per se, but it's that they just have not come into network. And I think that's a lot, and I don't want to speak out of turn, the CMEs can certainly correct me. It's a little bit of the nature of the services they provide. It's not an easy, I'm a mental health clinician, and that's all I do is I see my patients, I teach therapy. It's much more complex, and the range of services is much broader than what they're providing to these kiddos. So it's not such an easy line to reach out to Anthem and say, hey, I want to come in network. They know the codes, they're using the codes. It's traditional set of services, so to speak, CMAs. It's a little bit of a more unique mix. So to maintain the integrity of that, I don't know that it's a network adequacy issue per se, but if I'm not answering your question, please let me know.
No, Jennifer, you're okay. So are there any points where where there are zero providers offering, care within networks?
I don't think for this particular set of services, I don't believe so, because I mean, the clinical service, what we're looking at from the department in terms of network adequacy would be those clinical therapy treatment services. There are some of the other parts of the bundle are not necessarily thought of as services that would be reimbursable through traditional insurance, but in this instance, that's why we're trying to build the amendment in such a way that they're not excluded, because we want to maintain the bundle and keep that service intact.
Second question, not complete. Okay, so now I'm going to go to the front. Thank you. You've outlined the history of working on this issue, and it seems like there's a level of optimism that we can come to some type of agreement through an amendment. But let's talk about this amendment. It moves away from the proposed model and takes us to a place where the providers are solely responsible for these services. You said they're going to bundle and stay together. Because I want to know what happens when they've met their coverage limits. Right now, isn't the state covering through they shift to the Medicaid program? I'm trying to understand when you talk about the bundling, how that's going to take us all the way. It sounds like it's going to take us all the way through or not.
I don't know that I can properly answer that question. That's a little bit outside of my wheelhouse. I think and I apologize, I know Michelle could probably answer it better than I could, and maybe the HHS folks could. Keith, I don't know if you want to give it a try.
I was going to ask you to try to rephrase the question slightly, Senator, which is, I believe I heard, are the services really being provided today? And how can we break up the bundle to make sure the services are still being provided? Or
it sounds like you don't want to break up the bundle.
No.
You want to keep it together in this amendment, move away from the assessment model. So I'm just trying to understand where the coverage from the commercial carriers takes us, moving away from this model. If there's anything that isn't covered, is that going to the state? Like who's
yes, that's the short answer.
Trying to get.
Yes. So thank you. So the clearest way I can explain it is because we have heard the stakeholders loud and clear on this. They do not want to unbundle that group of services, and we appreciate that.
Yeah.
What the amendment is seeking to do is unbundle the payment. So it's going to parse out that payment a little bit more, what components of this can get reimbursed through regular commercial insurance. And then we're all, I think, in agreement, there is going to be a little bit of a delta because there are some services that are a little bit more supportive or services that are not traditionally covered by insurance. They certainly still have value to these kiddos in helping them get moving forward and being successful. So that's why we were really adamant about not unbundling the service for them, but just the payment side on the back end. So, but once commercial insurance starts being billed for the pieces that we can cover, we'll know what is not being covered and what's a more accurate need for the state to come in and reimburse so that it maintains the bundle, but we're trying to really flesh out the back end of it, so to speak, in terms of cost, who bears what cost. And in some instances, I mean, we would venture to guess that some, and we could be wrong, but I mean, if they were to go by billing insurance, they might actually get reimbursed at a higher rate than what they're getting from the state for this bundle, because depending if they come in network, if they don't, if they go with the QPA, they would certainly get higher than out of network. So there is a potential there that there's some money being left on the table by the providers if they're not billing insurance. So it opens up that can of worms, but we don't know that until we start seeing some of these bills come in to see what is the actual cost and then what would be the delta for the state to pay, if that makes sense.
It does, because the delta, you just explained what that is, at the heart of what I was trying to get at.
Yes.
Just one quick follow-up, and I'm going to thread this through a number of the groups that come up today, but are there any other models or any other, say, I'm thinking, medically, services that carriers, that they provide that look like this, where they hit a limit and then they go over to, to the state for Medicaid coverage? Like there's.
I'm not aware of any, Senator.
Okay, so this would be unique.
Yeah.
Okay, thank you. Good, you got it. Thank you. Yes, I am, thank you.
Senator Avard.
Thank you. So we heard that you want to move away from the assessment. I am looking at this one. Year. I should have known that. So moving away from the assessment model is what I was getting at. So does this have any effect if we haven't seen the amendment, right, on the fiscal note?
I think it would change the fiscal note just by the nature.
Up or down?
I would speculate.
I would
downward.
speculate down. I know
Speculate down.
Michelle could provide that analysis, and we're happy to do that. We have it, the majority of the amendment drafted, so for sakes, before it even gets moved over, I mean, we can do that fiscal analysis ahead of time, just so that what we're considering to even know, would the shift be up or down, so that prior to it being introduced, we can play that out for you. We can certainly do that.
Yeah, not to be missed in the conversation, but you also mentioned that the areas that weren't maybe covered, that might be grant money available?
Well, no, what we were considering was for grant money and this was kind of an idea trying to find a way to help the CME providers who are not set up, like they have systems essentially that are not set up to bill insurance. And they potentially have staff that are not used to billing insurance because they're used to be reimbursed in a different way. And they can certainly speak to that far better than I can. But we would be seeking a grant collectively, and this is all of the groups of stakeholders would support this is what the discussions have been so far, is to seek a grant to try to provide the assistance to the CMEs so that cost is not coming out of their operating budgets, because it's certainly not something that they have planned for or anticipated, but it could help them get over that hump to start billing, and hopefully get that moving along.
Thank you. Final question, if I may. And so you folks didn't even touch on this, but it's always in the back of my mind these days is, are there any compliance issues that this will affect one way or the other with the mental health with children?
None that we're aware of.
None
Senator.
that we're aware of from the insurance side of things. I don't know if HHS, I don't believe from their side, but I'll certainly let them speak to that on, I don't want to speak on their behalf.
Just out there in the universe, it seems like it's always there.
Certainly I think it being a new program, there are some issues that would need to work through. But I think that's where, as Commissioner Betancourt mentioned in his letter, there's been a lot of cooperation, there's been a lot of positive collaborative work where I'm pretty confident we can bridge those gaps.
Thank you.
Any further questions from the committee? Senator Birdsell.
Thank you. Just one last one. So we talked about the fact that a lot of interaction was done before Christmas, but there has how much has been done recently on any of this, or is it kind of stalemated?
I don't believe at all that it's at a stalemate from everything that we have understood. So the departments were kind of shepherding this along through the fall. And then we got to that position where we were going to just take a small step back from the department's perspectives to allow the CMEs and specifically Anthem, since they had the most kiddos that looked like they were part of the mix with those providers, to kind of come together from there to start working to see, could we potentially get in contract with you, and would that maybe be something that we don't need a legislative solution for if they can just get in contract. To my understanding and speaking with Anthem pretty regularly, that those conversations have been going forward. I know that there's maybe been just a little bit of hiccups because they're kind of trying to learn one another's processes, which I think can be anticipated. There's some information sharing that's had to go back and forth. That's, again, they're maybe not traditionally used to sharing that information. So some time spent pulling that together, going back and forth. I know that there's been a pretty good sized team at Anthem that's been trying to work with the CMEs to try to see if they can move this forward. So as far as I know, and I think Sabrina can give you a much more current update where that's going. But so even though we have stepped back a little bit, we've been checking in with, from our side of things, the Anthem pretty regularly just to see how are things going, are things moving along. And even though it might seem a little bit slow from folks looking, it is actually being accelerated from a contracting perspective. They have really kind of dropped what they're doing in some other regards to kind of put this to the forefront, knowing that this legislation's been going on for a couple of years now. And if this is a viable path forward, let's kind of put a lot of energy towards getting it there. It is just a process. Any contracting with anybody, it's just a bit of a process, but they have really tried to accelerate that. And I think Sabrina can speak to that. But from our perspective, it seems as though things are moving along pretty smoothly. It's never going to be as fast as we would like and have this be resolved right away, but I think everything's moving in the right direction.
Thank you.
And I would echo that. I mean, we're working on other projects. We'd like to get to a non-legislative solution.
Yeah.
Anthem has kept me updated throughout the whole process, and not necessarily specifically to 498, but in general.
Yep.
And if you think government moves slow,
Exactly. Exactly.
But I can relate to that. So thank you. I'm glad to hear that you're seeing the same observations.
Yes.
Any further questions? Thank you very
Okay,
much.
thank you.
Chair calls Jenny O'Higgins and Marissa Henn and Daryl Tenney from DHHS.
Good morning. Thank you so much, Chairman Rochefort, members of the committee. A special thank you to Senator Birdsell for her leadership around the mental health needs of kids and families in the state of New Hampshire. So for the record, my name is Marissa Henn. I serve as Deputy Commissioner at the New Hampshire Department of Health and Human Services, and I'll let both of my colleagues introduce themselves.
I'm Jenny O'Higgins. I'm the Legislative Liaison for Behavioral Health at DHHS.
And good morning, I'm Daryl Tenney, the Bureau Chief for the Bureau for Children's Behavioral Health at DHHS.
Great. So DHHS is not taking a formal position on the bill right now, but I do think it's important to back up a little bit and provide a bit more information about why this issue of fast forward matters so much to the state and to the Department of Health and Human Services right now. And I want to clarify a little bit around the possibility of the amendment that was discussed. So I'm speaking to the idea in concept. So Fast Forward is New Hampshire's high fidelity wraparound program for children and youth with the most complex mental and behavioral health needs. It serves youth ages 5 to 21 who have significant mental health issues. So these are children who are truly struggling. They often have significant trauma. Home life, because of their mental health condition, is extremely chaotic, and they have not been successful with traditional outpatient therapy type services. they are at risk of being removed from their homes and placed in costly institutional care, whether that's an inpatient psychiatric hospital or a residential treatment program. So at its core, it's really important to understand that Fast Forward is not a collection of discrete services. As others have said, it is a bundled, team-based approach. It's individuals sitting around a table like this, working as a team with all their different disciplinary skills, therapists, psychiatrists, people who prescribe medicine, other adults involved in the child's life saying, what does this youth need? It is driven by the needs and preferences of the youth and family. It is based in community and oftentimes right in the home, and it is delivered right where the families need it, so they don't have to go to some sort of office or institution to get care. So I want to emphasize that. The bundle is what makes this so efficacious. It includes coordinators, peer support, flexible supports, team meetings, crisis meetings. This is not just a therapist in an office. This is not just a doctor prescribing medications. This is a team-based, holistic approach. And that is why thinking about issues of in-network or fee-for-service services is almost apples to oranges, because what we're talking about here is a situation where individual billing codes, even if individual billing codes exist, we're not talking about that full holistic bundle. So why does it matter? Fast Forward, and I don't come to many hearings, but I come and say this with tremendous confidence, is a game changer in the state of New Hampshire and across the country. Thanks to Fast Forward, we have been able to prevent costly institutional care for our most vulnerable kids and families. It strengthens families. It saves state resources. If you've ever looked at how much it costs to stay at Hampstead Hospital for one night, it is a huge number, let alone for an entire course of treatment, let alone needing to be cared for perhaps out of state. So we're saving state resources, we're getting families what is needed, and we're dealing with their underlying issues. I want to stress that we have seen this work in the state of New Hampshire. I don't know if you have ever thought about this, but how did DHHS get the number of kids served at the Sununu Youth Services Center from 75 to 12 in 5 years? It is this type of program. Why? Because it actually meets the needs of families that are in crisis, that are struggling with an array of complex issues, and it prevents them from needing that costly level of institutional services. So I won't bore you with the evidence base, but it's extraordinarily strong. We have lots of data, and we know it's already making a difference in our juvenile justice system and beyond. So the budget reality. Why are Jenny and Daryl and I staying up at night thinking about this? Not just the opportunity for expansion, but the current nightmare situation we're in. I want to be really candid. DHHS is in a very difficult fiscal situation right now. We have to use those state general funds, taxpayer dollars, to cover many kids in Fast Forward, about 20% of them. The vast majority of kids are on Medicaid. They are covered with a 50-50 match, but there's still a large, to the tune of about $2 million a year, that we are putting taxpayer dollars toward covering kids who have commercial insurance. In practice, this means that public dollars are subsidizing critical care for children who have commercial insurance. But it also has another consequence, which is we have finite dollars to serve the kids in the program right now. And as their needs, as we all know, we're dealing with really complex times for families and a mental health, rising mental health need. Our care management entities that deliver this service are having to cut back. And you'll hear more about this from them, but the services that kids in the program are getting right now is decreasing because of lack of sustainable funding and because of the fiscal situation DHHS is in. So this isn't just an emergency on the horizon, something that we want to deal with long term. It's actually playing out for our families right now. And so because funding has not kept pace with needs and because of the intense dependence on general funds, our programs, who you'll hear from, our care management entities are having to make extremely difficult decisions about capacity, staffing, and service intensity. And this worries me because a program that we depend on, that families depend on, it risks not being as robust as it could be and needs to be without sustainable funding. So again, I want to just emphasize, DHHS doesn't have we're fairly agnostic about how this gets done. We very much would love to see the insurance carriers and the care management entities come together and use the forces of market process and competition to work this out. But what we know is that we have an emergency on our hands where families are already having their services curtailed through this program, and we're not going to be able to accept more families, which could be any of our kids, any of our nieces and nephews and neighbors, who have quality commercial insurance, if we cannot figure out a way to come together and solve this. So we are very open to amendments. We're very open to an array of possibilities for how this works. But what we're speaking to is the profound need and the fact that in order for that amendment to move forward, we have to see significant progress in conversations between the carriers and the CMEs, which I know are happening presently. So I'll stop there and welcome questions for our team.
Are there any questions? Senator Prentice.
Thank you, Chair. And it's
Marissa.
Yeah. Marissa, Deputy Commissioner?
Yeah.
Okay, great. Thank you. Nice to see you all today. So, what happens? So let's talk about the cost difference. Community-based services versus inpatient care. Do you have a number? Like what it costs for somebody to spend, what it costs for one of these complex cases to be at, say, Hampstead Hospital for, for 1 night, 2 nights, 3 nights versus the fast forward services that are community based?
Yeah, great question. I'll take that one. Again, for the record, Daryl Tenney, Bureau Chief, Bureau for Children's Behavioral Health. I'm going to give approximates because I don't have any data in front of me, but an inpatient psychiatric hospitalization's around $1,500 a night. So just sort of that, setting that as a comparison. We're seeing about 65, anywhere between $45,000 and $65,000 per year for this particular service for Fast Forward. The daily rate for the bundled service really ranges around, it's around $77 per day for the care coordination, and then you would add on the family and youth peer support that may be billed. So it's a much lower daily rate for that intensive service. And then just providing you what an annual cost if a family is enrolled in the Fast Forward program is anywhere between $45,000 and $65,000 per year.
Yeah, and I'll just add that residential treatment, including, it's been, quite high profile in the news of kids who have to go out of state. It's not uncommon for those kids. We're talking $500,000 a year, $500,000 a year, even or higher. So relative to a program that's meeting their needs while they're still going to school, living in community, and engaging with their families.
And I will just add one point. So I kind of provided a wide range. 45 to 65 is quite a wide range. Because it's such an individualized program, it's really highly dependent on what they need for individualized clinical service. So 65 is really thinking about those families that need those more intensive clinical services potentially as part of that plan of care.
I have 2 more. Can I do one and then maybe,
Yes.
I'll do one and then Senator Ahern. So thank you very much. So is it your position, what I'm hearing is that the real need right now is to fund the Fast Forward because that is a more cost-efficient, community-based model, and because we're in the situation we're in, it's costing the state more without a mechanism to fund Fast Forward. So the current model is costing us much more per day, per month, per year than implementing Fast Forward.
Yeah, I think there's 2 ways to think about the costs from a public standpoint. One is that the actual return on investment of doing Fast Forward through this high fidelity model that the care management entities deliver actually deals with underlying needs. So you're talking about families that could have trauma, perhaps there's been divorce, there could be other array of issues. Fast Forward is actually helping stabilize that family for the long term. We know that many kids who go to residential treatment or inpatient psych will cycle through that many times. So from just a raw return on investment by dealing with the underlying family and home ecosystem, you're talking about a much higher value of service that over the course of that child's life. The other part of the cost is avoiding this high intensity care. We really want families to be served in the context of home and community. We do not want to be sending them to programs in the region or out of state, because we know that while that can meet the short-term need, it rarely works to pluck a kid out of their home and community, put them in even the best program, and expect that you're going to fix their issues there and return them back to the same place. And those programs are extraordinarily costly to the state. As I said, not uncommon to be talking close to $500,000 for a child to receive care in such a high intensity residential program without the same return on investment that you get from Fast Forward.
Sorry. Well, kind of piggybacking on what you are thinking with regards to the children that are being sent out of state. I mean, that's costing a lot. How many are we talking about?
So we like to think of it, so out of state, we generally frame it as out of region, because for some youth and families in New Hampshire, the border states are actually physically closer than another location. So I think right now we have approximately 10 youth, is that give or take? Six, okay. 6 youth being served out of New England at this time. And DHHS is soon going to be announcing a major initiative called Keep Kids Home, where we are committed to reducing that number even further as we better meet families' needs through programs like this.
Is there, I asked earlier about compliances. Are we within, are there any issues with compliance with the feds at all? That
Yeah, no, from my understanding, no, no impact on compliance.
So, if I may, yes. I don't want to hog your time. Yeah, so we're looking at approximately 6 children at $500,000 apiece that we're not able to treat because we don't have the funds. And so this bill is looking at like $2.5 million per year to cover expenses that are needed for Fast Forward, depending upon what the amendment.
Financial pieces. So what we're talking about when we're talking about the inpatient care is a little bit separate from this bill. It's what happens when we are unable to get kids into Fast Forward and those crises continue on, right? So we're saying without being able to have a scalable and sustainable funding mechanism for this program is keeping kids more often in home and allowing them to get well, and more often than inpatient care can. And so the ability for us to scale this and continue to see its success over time is what will reduce the need for those inpatient residential pieces of care. And over time, if those needs increase because there are less children having access to a program like this, then that number, that cost to the state goes up and up. The number you're seeing in your fiscal note is specific to the number of children who are receiving these Fast Forward services, the in-home care. And of all of the children receiving Fast Forward, approximately 20% of them have commercial insurance. So then when a child comes in on commercial insurance for the Fast Forward program and it isn't covered, the state will try to figure out if they can qualify for Medicaid under the HCCSD program, and about 70% of that 20% that have commercial insurance qualify. So we're going from 100% of kids in the program, of that, 20% of them on commercial insurance, and I'm just rounding the numbers, but we have the hard data for you. But about 20% then are commercially insured, and then about 70% of those 20% can get on that Medicaid coverage. That's the number that's in your fiscal note. It's the one to approximately $2 million annually that is being covered by state general funds when there's a gap where the children do have commercial insurance and can't qualify for Medicaid. We then pick them up with state general funds to make sure they can still have access to the program.
Senator, may I just ask one more, then I'll bring it over to you.
Go for it.
Thank you. And so I'm got this number of 6 children in my head. How does this affect them then?
So those 6 children are being paid for out-of-state care. And what we're saying is that this program is such high fidelity and has such great success that if children had access to this program, earlier intervention would have a better outcome for them. So we're trying to reduce the number of children that get to that high level of care for inpatient need.
Yeah, and it's also how we get kids home from these settings. So as Senator Birdsell knows well, because Hampstead Hospital, as well as the residential treatment, kids can oftentimes, we don't have a way for them to get out of these institutional settings because their home is still a really complex place. And so what Fast Forward also allows us to do, and the other programs offered by the care management entities, is to step kids down from residential treatment or from inpatient hospitalization so they aren't languishing there for days, weeks, months, longer than is a psychiatrically appropriate stay.
I'd like to add just one more comment to that because understanding that the number 6 sort of sits with you a bit. It's not necessarily the number 6 that should sit. I mean, I think number 6 represents a number of youth that are out of state, as Deputy Commissioner Henn in a point in time. That number has been reduced significantly over time because of programs like Fast Forward and what we're providing here for testimony. It's these preventative approaches to be able to help reduce that number to a single digit. Years ago, prior to this program really being able to be launched, those numbers were much higher. We are seeing much more, many more youth in higher levels of care. So I guess I just want to testify and just reflect upon, we talk about the number 6. Our hope is that we can prevent all 6 of those youth from even needing to go to an out-of-state placement or episode of treatment. And Fast Forward has been significantly helpful in reducing that.
And there's about 200 who are in programs in the region. So those kids are also really important recipients of programs like this who may not be out of region, but they're still out of home.
Senator Birdsall.
Thank you. Good to see you again, Marissa. So those, I know we don't want to concentrate on those 6, but if we had space in the Fast Forward program, they wouldn't be in outplacement, out of state.
That is the primary goal of Fast Forward, is to prevent youth from needing those higher levels of care. And that number has reduced over time for absolutely. Thanks.
Senator Prentice, did you have another question?
I do. Thank you, Chair Rochford. And Jenny, I think you can maybe help me with this. So let's go back to 20% of the 20% of these children have a commercial insurance. They're covered by commercial insurance. And 70% are what is being paid or accessed through commercial insurance that's currently covered. 70% of those kids?
No commercial insurance coverage of those kids. So of the 20% that then have commercial insurance, about 70% of them then qualify for the HCCSD Medicaid. And so then the state pays through Medicaid there, and then there's a gap of the 30% that don't get picked up by Medicaid, and that's your state general funds that you're looking at in your fiscal note worksheet.
It ends up being about 50. We just started collecting this data in a more detailed way in July. So I think we estimate about 60 kids a year who have commercial insurance but are not covered by Medicaid, but need Fast Forward.
Yeah.
Yes.
So that 30% is where I'm trying to go. They are covered by Medicaid?
Or not.
Or they're not covered. So what happens to them?
I got to give you a drawing. I wish I had a whiteboard, right? Because the percent of the percent gets confusing.
No,
so they get the 30% that is the
30.
gap that is not covered by anything gets picked up by state general funds. So all of the kids still have access to the program. The real concern is the budget constraints that we are picking up a percentage of children with state general funds. We're picking up children on this expanded Medicaid program. And then we have regular Medicaid coverage. And those are really the 3 ways that it's currently being covered. And with the percentage of kids who have commercial insurance, if they had additional coverage through their existing commercial insurance, it would reduce the burden on state funds.
So that,
Yes.
So that additional coverage, that you just stated, that is what we're trying to not say cost shift to the state, but redirect that and find a way to fund it.
Yes. And that's about 50, that percentage of a percentage is about, we think, around 50 or 60 kids a year.
Just quickly, may I?
Yes.
And I asked this question of the Department of Insurance, so I'm just going to bring it back here to you. Are there any other medical, clinical, intensive, high fidelity, complex wraparound intensive services like this that have that same, say, gap where the state is picking up the coverage?
But I'm Moira.
Thanks.
Any other questions of the committee? No, thank you very much. So we've heard from the departments. We'll start with our other testimony, and with that, we'll be limiting testimony to 3 minutes, and the chair will call Sam Hawkins.
Good morning. Thank you for the opportunity to testify today. For the record, my name is Sam Hawkins. I'm here today representing NAMI, New Hampshire, in support of Senate Bill 498. You've already heard a lot about the Fast Forward program. I would just like to share that as a provider of family peer support services through this program, we at NAMI, New Hampshire can attest firsthand to its really positive impact that it has on those who are able to access the program. And you'll also hear from some advocates today about the positive impact it had on their families. However, we have also heard that currently commercially insured youth are not able to access coverage for these services through their private plan. I'd also like to point out that even though there may be services offered through their plan that may sound similar, truly there is no comparison to the quality of services they would receive through Fast Forward. Those services they may be able to access are not as intensive as Fast Forward and do not hold to the same fidelity of the model that we know makes it work through the team-based model. So for those youth, they are essentially, and their families, they're essentially left to wait until the youth's condition declines to the point that the state picks up the tab and the taxpayer picks up the tab, even though they've continued paying for their commercial plan. So this is not just a funding issue, it is an access issue as well for these commercially insured youth who are paying to access these services. So in regards to any amendment that may be drafted and proposed, I would just push a lot of caution that we really do need Fast Forward services to be covered in the full bundled suite, rather than a picking and a choosing of what services the commercial plans may cover, because we understand it is this bundled suite that makes it work. And just allowing the plans to pick which services they will or won't reimburse for is essentially no different than the status quo. We may hear that some of these services are considered social services, and that's why they are not reimbursed. But I do expect you all hear from the advocates in here today that without these services, their family would not be as happy and healthy today and would have experienced much worse long-term outcomes. In regards to that, Senate Bill 498 is the model we have right now to ensure access to Fast Forward services for commercially insured youth so that they and their families can experience the positive outcomes they need. So in that regard, we ask you to please support Senate Bill 498 and ensure access for these youth. Thank you.
Great, thank you. Are there any questions from the committee? Senator Long.
Thank you, Mr. Chairman. So you mentioned that it's also regional. Is it by areas of the state where there would be more youth that wouldn't access Fast Forward? Or because there's no local base services?
So thank you very much for the question. I would defer most of that to some of the care management entities who are in the room because they would be able to speak much more technically to it. We do have 2 care management entities that work through the Fast Forward program covering different regions of the state. So there is coverage for these services for Fast Forward throughout multiple regions of the state. The issue is that these commercially insured youth have no way to pay for it through the plan that they have until their condition worsens and the state pays for it.
Very good. Thank you.
Are there any questions for Senator Birdsell?
Thank you. Thank you for taking my question. I think it was the insurance department, when they came up, or HHS, I can't remember which, but in that amendment that they're all trying to work through on, and I know it's taken a while, they are trying, it sounds like they are trying to keep the bundles together. There are going to be pieces that the insurance company probably can't cover. But do you agree that from what we've heard, they're trying to keep everything bundled? Because basically HHS said that's the important part of it.
Thank you for your question, Senator. I would say I would probably have to read the amendment to say definitively. I would say sort of the large issue that we've been studying about this for so long is that it is these so-called social services that the commercial plans wouldn't cover that are why we're in this situation. So if the state is to continue paying for those services, as it sounded like that amendment may be drafted, the numbers may look a little bit different, but I don't see how it would be substantially different from the situation we're in now. But I would have to look at the amendment for sure. Thank you.
Thank you. Any other questions? Thank you very much.
Thank you.
Chair calls Dennis Calcutt. You turn your microphone on there. Yes, thank you.
Thanks for your time. Thanks for your interest in this. My name is Dennis Calcutt. I'm the director for Connected Families New Hampshire, which is a department of Cheshire County, and we are one of the 2 care management entities. So as you get into specific questions, we can talk about it on a very specific basis with respect to how these families are ending up where they're ending up and why we think the support is needed. I'm testifying in support of the bill. New Hampshire children and families are suffering. If this was cancer, I don't know if we'd be having the same conversation, but we should be having the same conversation. The outcomes for children with serious mental health issues and the outcomes with children with cancer are similar if they're untreated. What we are providing is an intensive care coordination service. As you've heard in the conversation, we've talked about a bundled service. The bundled service enables us to bring the team of people together to help that family make the decisions to move to a different place in this process. So we have family peer support, who you'll also hear from. That is provided through NAMI New Hampshire. At times there's youth peer support. But the goal is coordinating the care to ensure that the families have the care that they need. And that's really important in this process. We have children awaiting care in emergency departments. We have children who are in residential treatment. I think they're there because we don't have enough in the continuum of care. I think, and I think I've said it to this committee before, but we know the majority of the population knows what therapy is, and the majority of the population knows what a psychiatric hospital is. But what's in between there? What's important to families? What they need to have? Sometimes can be a specialized therapy. Sometimes it could be therapy 4 or 5 times a week, but it's focusing on care in the community to keep the children and families in their home community. Anytime you look at services if you're looking at the tiers of services, if you're looking at the end near psychiatric hospitalization, the cost goes up and you're further away from the community. So our goal in working with these families is to keep them in the community, keep them connected to the supports that are around them. Some of those are very natural supports. I jokingly say it's like who'd they watch the Super Bowl with? Those are natural supports. But then it's also, could be someone at the school. It could be someone at the community mental health center. So it's really looking at that comprehensive list of services. As care management entities, we are contracted through the Bureau for Children's Behavioral Health. This is an evidence-based practice. So it's not as if we're just saying, let's build a team around the family and help them get what they need. In an evidence-based practice, it's really an intersection between the research evidence and what's in the literature. Well, that's quick. Can I have a couple more minutes or one more? Okay. Yes, but then clinical expertise and then the family values. It's really bringing the families to the center of the process, and that's the most important part of this process. And over the last 15 years, we've developed this process through funding initially from SAMHSA, the Substance Abuse and Mental Health Services Administration, to get this stood up. Now it's stood up. It's working well. We have, it is life-changing for families who are in this practice. And that's what's really important to note here.
All right, thank you. And it looks like you're reading off notes. If you could forward those to Sophie, she'll get those to all of us. So You know, 3 minutes goes by quick, so.
does.
But she'll make sure we see all your notes and have all of that. So,
Yes.
are there any questions from the committee? Thank you very much.
And I appreciate your interest in this.
Thank you. Luke Reynard, Chair Calls, NFI North.
Am I on? Good.
You are on. And 3 minutes goes by quick.
Yeah, so I hear. Good morning. I'm Dr. Luke Renard. I represent NFI North. I am the other care management entity for the state of New Hampshire. Dennis and I work very collaboratively to provide this service. I think, to be brief, I'm probably going to skip a lot of this because I think we're not arguing about the tenets of the program. Even our work with Anthem, we all see the validity, the helpfulness of the program. Where we're stuck is how to finance it. I know from NFI's perspective, we are a statewide program. We serve every county. We have employees who live in every county. What we've noticed over the past couple years is that our percentage of families that come to us without coverage is increasing. About 4 years ago, it was 20%. This past year, it was 31% came in with without Medicaid. So either commercial coverage or no coverage. Our bucket of state general funds has not increased. So the unfunded mandate of the portion of the program continues to increase. We have a number of painful decisions to make because this percentage grows proportionately. We've cut out raises this year. Unfortunately, we've had to limit subcontracts that go to the efficacy of the program, and we've lost staff. So the bigger this problem becomes, like the more repercussions we're going to face, and fewer kids are going to get this service is the reality of it. We have worked collaboratively with the insurance companies, specifically Anthem. NFI has 31 people that have Anthem coverage that have come to us in the last 6 months, is the data we looked at. Again, I don't think we're arguing over the merits of the program. I do think there's a disconnect on committing to a bundle and then, of course, the contractual process of negotiating a rate. So we are early on in the progress of talking. I think there's a lot of work to go, but it's probably closer than we've been before.
Great, thank you. Senator Abart has a question.
Yes, thank you. See, 3 minutes just got expanded. How's that?
All right, look at me.
All right. I'm hearing social services that aren't covered. What, under the umbrella of that title of social services that aren't being covered, are we talking about?
So I think when you look at the wraparound bundle, and admittedly, I am not the expert. We do have team members in the audience if you have further details, but a lot of times when we're discussing these with the insurance companies, we look at clinical or medical services versus a social type service, right? So for example, we get a daily rate. Daryl mentioned $77 a day, and there's peer service, which is billed at a 15-minute increment. That's in some models, and that's a Medicaid code, not an AMA code. So this peer support is billed at a 15-minute increment. It can be considered as a social service. It's not a medical provided service. There's not necessarily a clinical background to there, although we know the social benefit is huge. There are other components of the model that are not provided by a licensed clinician, for example. We have team meetings. We have elements of the evidence base that we have to provide, pulling in different areas of whatever the local team is. So I think the divide is you look at where's a medical code that says they're getting psychotherapy or child psychotherapy, right? So you have an established clinical code versus a social code where you get maybe more social work kind of things, local connections, bringing the family together. And I think that's where it doesn't fit neatly in the box. And that's what we're trying to build is the box.
Thank you. Any other questions? Thank you very much. Chair calls Katie Pingree, Katie Lyon Pingree.
Well, she's got a whole box of stuff.
Thank you. I want to be sensitive to your testimony. You've got a lot there, but we have a lot of folks signed up. So
Understood.
thank you.
Yes. My comments are brief. Good morning, Senators. My name is Katie Lyon Pingree, and I am here today in support of SB 498. This important bill would ensure that children and families with private insurance have access to wraparound supports designed to help them, guide them, and facilitate an environment in which healing can actually happen. Because the painful reality is that is not the mental health system we currently have in place in New Hampshire. Instead, what we have is a frustrating, confusing, seemingly impenetrable system that even those who are working in it struggle to navigate. When a child and their family are experiencing a mental health crisis, the last thing they should have to do is try to blindly operate within a system that appears built to fight against them. My son, Matthew, began struggling with his mental health as early as age 10, long before we knew it was a problem. Unfortunately, repeated sports-related brain injuries in adolescence intensified his struggles, leading to severe depression, anxiety, and persistent suicidal ideation from 2019 until his death at age 18 in December of 2021. Matthew's story is highly complex, but for today, I will focus on just one snapshot of our struggles. In September of 2019, Matthew tried to commit suicide in his bedroom. When my husband and I broke into his room and realized what he had done, we knew the standard prescribed choices for what to do next were only going to exacerbate the situation. We knew this because we had already experienced the trauma of a completely ineffective multi-day ER visit, followed by an equally ineffective week-long stay at a crisis facility in Brattleboro, Vermont. We had hoped to find another way that would be more supportive to Matthew and his needs. So instead of going immediately to the ER, we chose to sleep on his floor and call his therapist in the morning. When his psychiatrist called me back, she insisted Matthew go to the ER. When I objected and said it only made things worse, she hung up on me and called 911. This began a cascade of events which would ultimately lead to his 10-month-long stay at a residential treatment facility in Utah, separating him very painfully from his friends, family, school, and home. During the years that Matthew needed treatment, time and time again, we had to hunt for anyone and anything that might help him, not really knowing what all our options were and feeling like every decision we made was the wrong one. All of these files here are the result of those hard-fought efforts to wade through an overwhelming system alone on behalf of our child. If the Fast Forward program had been available to us as a privately insured family, we would have had a case coordinator, a point person who would have helped us navigate the system of care. We could have had additional family supports, people who knew what it was like to wake up every morning worrying if this was the morning you would find your child dead. Matthew could have had the opportunity to connect with peers with the same lived experiences so that he would know he wasn't alone. Most importantly, all of this would have been available to us at home, with providers focused on our family's strengths. Not only did we not benefit from any of the services that Fast Forward provides, we ended up paying almost $120,000 in out-of-pocket expenses in a 2-year time span. And while we would have gladly spent everything we have for Matthew, it wasn't enough. This pile of 170 sympathy cards we received after his death is evidence of that. Once again, I am here today on behalf of Matthew, urging you to please recommend that SB 498 ought to pass so that all Granite State families, regardless if they have private insurance or Medicaid, have access to Fast Forward to be able to help their kids to not only thrive, but to survive. Thank you.
Thank you, Katie. Are there any questions? Thank you for coming in again this year, and I'm sorry that you have to come in again this year.
Me too. Thank you so much.
Thank you. Chair calls Andrea Brochu.
Thank you for your time today. I'm Andrea. I am a mom from the North Country, so thank you. I'm here in support of SB 498 because I have a very similar story to Katie, but a different ending. So no parent ever thinks that their child or they themselves will struggle with mental health. No parent imagines being unable to access help, not knowing where to turn, or being told to wait while their child is actively unraveling. We believe those things happen to other families until suddenly it is your family, it is your child, and it is your reality. And when that moment came for us, the system I expected to catch us did not. Before Fast Forward, we were completely lost. We were navigating barriers at every turn, receiving conflicting information, and being handed phone numbers that led nowhere, managing and navigating the mental health and education systems became a full-time job on top of a full-time job. Every day was triage, every day, every call felt urgent, and every delay felt dangerous. I want to be very clear about this next point, though, because it matters incredibly deeply. I am an educated professional. I have spent more than 15 years working across nonprofit organizations and social service systems throughout this state and now nationally. I know the language, I understand bureaucracy, and I know how revenue streams work, and I was still lost. I was overwhelmed, I was exhausted, I was terrified, and despite advocating relentlessly for my son, we repeatedly ran into closed doors, waiting lists, and systems that required us to fail further before help was offered. If I, with all of my knowledge, experience, and privilege, was struggling to navigate this system, imagine the parents who don't have those tools. Imagine families working multiple jobs, families who don't speak English fluently, families who don't know how to push back when they're told no, because you're told no a lot. Their children don't just fall through the cracks because the cracks are the system. Our situation deteriorated to the point where we were forced to place our son in residential care multiple states away from us. We paid well into 6 figures for that placement out of my own retirement fund in the desperate hope of saving our child's life. And let me be clear, that was not a choice, it was survival. Our son was failed by the school system, our son was failed by the medical system, our son was failed by local resources, our son was saved by Fast Forward. Both my son's father and I were employed. Our son was covered by private insurance, yet the only way for our family to access Fast Forward services was to which ultimately stabilized our family, was to apply for Medicaid.
Time's up, Andrea, but I have a question for you.
Please.
Can you please continue and read the rest of your testimony?
So we were ultimately stabilized with Fast Forward through Medicaid. And that should stop you in your tracks, because when you are paying into a system, when we are paying into private insurance, why are we being required to pull from funds that are already coming and being needed for another program? So we should have had coverage for those benefits within what we were already paying for. These costs should not have been pushed onto another system through a loophole. This is not a tax. This is appropriate utilization of funds at a time where everywhere we turn, we hear about record-breaking profits. It is a moral and ethical imperative that carriers cover the needs of their participants, and it's a moral and ethical imperative that societal failing when carriers do not cover the needs of their participants. Families, coverage participants should not be burdened with costs so extreme that they are unable to access services or are forced to make decisions that negatively impact their future. Parents will do anything to protect their children, and that's a given, but it is not solely the responsibility of the parent when there is a broader societal responsibility, especially when the long-term outcomes, positive or negative, impact us all. Why is a program that serves families across income levels, across communities, across complex needs being funded almost exclusively through Medicaid? an already strained system designed to serve our most economically vulnerable populations. This reliance creates an unnecessary and avoidable drain. And the challenges my family faced were not rooted in income. They were not the result of neglect or effort. They were the intersection of genetics, environment, and a broken school system that did not prioritize my son's well-being. But Fast Forward met us where we were without judgment, without assumptions. They offered understanding when we felt blamed, safety when we were scared, and support when we had nothing left. The path to healing and thriving was not linear, but it was possible. There were days when nothing seemed to work, days when hope was hard to hold, and days of incredible progress and joy. Every single one of those moments was supported by our Fast Forward team. We were told, I'll close with this, we began this process being told that my son would be lucky to graduate high school with a basic state diploma, that he wouldn't amount to anything, and that we should just give up at that point, that his struggles were his fault. Today, he is thriving. He was placed in the right educational environment. He became a straight-A student almost overnight. He became a leader among his peers. He has held down a part-time job through high school. He graduated early last month, and he is now attending trade school. That's because of Fast Forward. And that is why I'm in support of this bill.
Thank you very much. Are there any questions from the committee? I have a question for you. We're going to be hearing about increased premiums, increased costs. Would your family have been willing to pay a little more in premiums if they had known that these services would be covered?
Absolutely.
Thank you. Chair calls Kristen Shepard.
Good morning. My name is Kristen Shepard, and I am a registered voter and resident of Derry, New Hampshire. I'm here today to request the committee to support SB 498 that will provide private insurance companies to cover the very important service of Fast Forward. By passing SB 498, this will allow families with any type of insurance to be provided with the opportunity to work with this extremely important, intensive outpatient mental health service. In 2021, my son Christopher began a series of trips to the emergency room. We would go in and be released due to there not being enough mental health beds in the state of New Hampshire. We would go home, hope for the best, things would escalate, and then we would land back into the local emergency room with yet another mental health crisis. This rinse and repeat pattern went on until the end of 2021, at which time our son went into residential care outside of the state. During that time, my family had the Fast Forward service. This was only possible because our son had Medicaid on top of our private insurance. Our son was adopted through the foster care system in the state of Massachusetts, so we were allotted Medicaid as a subsidy for him, and I would not allow them to drop it when we moved to New Hampshire. The Fast Forward service was the first time my family felt connected to something that could truly help. As a social worker of 32 years, I am abundantly clear on the mental health service. I am a private practitioner. I own my own practice. I'm licensed in 4 states, and I know mental health inside, outside, and upside down, and every insurance avenue you can make. However, when our own son is having the first psychotic event and having, severe mental health emergencies, it was extremely difficult, if not impossible, to put my social work hat on and help my own son. Fast Forward helped my husband and I. While our son was in the hospital, we always had a lifeline to our Fast Forward social worker, a family peer support person in NAMI. And although our team was larger than those 2 individuals, it was those 2 that helped my husband and I as we watched our child go through the throes of his first psychotic episodes. These 2 amazing individuals provided us with guidance. They provided us with an ear to listen to when we needed to vent over the situation, and would particularly help me think rationally what I needed to do next for my son within the system. Fast Forward not only saved my son's life, but it saved my family. And I don't know where my husband and I would be if we didn't have that support. Any family in any sort of mental health crisis deserves to have all available resources to them. Mental health services should not be defined by which insurance somebody has. Mental health is found in every culture, every ethnicity, every class, every neighborhood, and is completely bipartisan. That's where it can help provide more to families than just those with Medicaid. I'm going to keep going. Understand that mental health isn't worse for the families with Medicaid. So why can't all those in need of help be provided with the same opportunities? As a social worker, if you add this into private health insurance, this provides another avenue of someplace I can refer families to. I'm going to leave you with one final thought. If your child or grandchild was having a mental health crisis, where would you want to turn to for help? And wouldn't you want to have access to every mental health service available to them?
Thank you very much. Are there any questions from the committee? And thank you for coming in. Cheryl Guerin.
Good morning. My name is Cheryl Guerin. I am a human resources professional and volunteer for NAMI New Hampshire. I live in Enfield in District 5. I'm here today as a mom of a teenager with a serious mental health condition. As a young child, my son struggled with anxiety. When he was 10, he started running from the school, wasn't able to get to school at all, and eventually unable to leave his room or his bed. I spent 4 years navigating New Hampshire's system seeking support and services, and our family faced emergency room boarding twice with him being restrained. 2 weeks at Hampstead, truancy, a JPPO, all kinds of terrible, terrible process. Simply put, my family was in crisis. This was a long process for my family during which my son and I did not receive the support we needed. I often think about where my family would be if we had gotten access to these services sooner. We eventually were able to access the Fast Forward program. Through the Fast Forward program, my family received intensive wraparound services such as care coordination and peer support. Looking back, participation in the Fast Forward program was the one key turning point in my son's recovery and had the greatest impact of moving my family out of crisis. So even though I had employer-sponsored health coverage, access to Fast Forward program was only possible once my son's condition worsened enough to be eligible for state resources funded by taxpayer dollars. It should not have taken years of struggle before things started to get better for my family. Years of struggle that no child and no family should have to face. Care coordination services and peer support are necessary and life-saving services and should be available to all families, including those with private insurance, and especially before those families are in crisis. Do you have any questions for me?
Are there any questions from the committee? Thank you very much.
Thank you.
Chair calls Paula Rogers.
Good morning, Mr. Chairman, members of the Health and Human Services Committee. Thanks for the opportunity to speak, and I'll be as brief as I can. I've listened this morning and concluded that one thing I think everybody can agree on is that the Fast Forward program makes great good sense. And so I'm not here to make any negative comments about that program at all, but I am here because I'm concerned about where the discussion has been going. And in some ways it's been productive and in other ways less productive. And I think what happened is when the bill was presented last year, which is pretty much mirror image to the bill this year, there was some confusion about what the purpose was. And the Fast Forward program, although probably a term that people were familiar with, it wasn't anything that people really understood very well. I certainly didn't understand it. So I've learned a lot about it. I was interested in Commissioner Hen's discussion this morning. I think it was illustrative. But what I learned after the hearing last year is something that sort of tagged something I heard at least 3 years before that, I think in the Health and Human Services Committee over in the LOB, where somebody was testifying and said something about their irritation with the fact that commercial insurers, and I was there not listening to a commercial insurance bill, commercial insurers in the Medicaid space. And I remember grabbing onto it and thinking, that doesn't sound good, or that doesn't sound right to me. What is going on? And then I never thought much about it until last year's bill. And so here it is. So basically what seems to be going on to me is that the Fast Forward program, understandably, does not align with commercial health coverage in its coverage extensions. When you get into areas around clinical matters, functional support services, and I think the last time I was in, I passed out a bulletin from the department. And the bulletin from the department, the insurance department, attempted to get at that issue, to clarify for providers what was likely to be covered by commercial insurers and where there might be some friction around certain codes where commercial insurers were not reimbursing because they felt their coverage didn't require that to be reimbursed. So we sort of moved that into the space we're in now, where you've got fast forward children who are commercially insured. It's been quiet in a way because ordinarily, and other states must face this, when you have a Medicaid coverage bumping up against commercial insurance, the commercial insurance carrier is out front as the first payer before the Medicaid program. And that comes from the federal level, and there are all sorts of regulations around that. So oddly enough, I don't think there were any CMEs, the two CMEs that run the Fast Forward program, billing. First of all, they don't have the capacity to bill presently. So and I hope I get off track here. So they don't have the capacity to bill presently. So what happened after the hearing last year, a number of us reached out to Jenny O'Higgins and Daryl Tenney, who were very helpful. We sat and chatted with them about this issue. We chatted about, well, how many kids are in this situation? How many commercial carrier kids are actually in a Fast Forward program? Well, this morning I heard it's up to 60, which was a bit of a surprise because I haven't had recent stats from DHHS, and I'm sure they're all valid. We were around 30. So what happened is, do you need to?
I was just going to say, so what are we going to do about it?
Where we're ending out is we now have some statistics. We know what the problem is. The carriers were convened by DHHS and the insurance department at a room in the big building on the state hospital campus that has the gables on it. And we sat there and discussed the difference. What could we do about it? And the directive coming out of that meeting was that the carriers were to sit with the CMEs, both of whom testified here this morning, and see if they could work something out. And what emerged was, because Anthem had most of the members in this situation, they would be the insurer doing most of that negotiation. So the negotiation now is, can we come in network in some capacity? If we can't, are there ways we can not unbundle the payments, but provide an appropriate compensation for a component of the bundled service that makes some sense? So that's where we are, and I have faith that it's a big problem in many ways, but it's also a very discrete problem that we could address firsthand and see where we go with that.
Great, thank you. Are there any questions for Paula? No, thank you.
Thank you.
And I am going to call Anthem next. So we're going to hear what the chair's going to call Sabrina Dunlap. So you know where we're at, Sabrina, with the conversation. So
I do. I do, and I appreciate that. And I did prepare a short version for today. I do think it's important to level set on a few things. So I'm going to try to stay. I will stay in the time. So good morning, Chair Rochford and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem. Thank you for the opportunity to testify. We respectfully oppose SB 498. We do not think it's necessary, and as drafted, raises serious policy concerns. But I want to just clarify a few things about the Fast Forward program, because I think the narrative about health insurance covering or not covering the Fast Forward program is incomplete and inaccurate. Fast Forward is a DHHS program designed specifically for high-risk youth receiving publicly funded behavioral health services. That's under 135F in statute. Historically, commercial carriers have had no role and no visibility into this program or the CMEs. The program is only delivered through the two care management entities. The fact that commercial carriers historically have not been part of Fast Forward does not mean there's a gap in children's behavioral health coverage between Medicaid and commercial insurance. There may be some gap. We've done a lot of work to make sure we can close it. Fast Forward is one program among many for addressing the behavioral health needs of children in New Hampshire. We want our members to have the right care at the right place at the right time. We provide a very broad coverage of a range of behavioral health services, including crisis stabilization, in-home supports, case management, residential treatment, and intensive outpatient services. Importantly, these services are covered through providers that participate in our networks. Historically, the CMEs have not been in our networks. Networks are one of the foundational concepts of health insurance, and they exist for the benefit of our members. So the situation with the CMEs is not that commercial insurance doesn't cover Fast Forward or wraparound services. It's not a matter of us not recognizing the importance of Fast Forward, which we do. This is about entities administering those programs who are wholly outside our networks and our systems. And that is the issue we are working on. We are working on that outside of the legislative setting. When the issue of commercial insurance and CMEs first arose in discussions around 2024, we asked for the data on how many of our kids, if any, were going to the CMEs. To that point, we had no insight into it. We didn't even know if our members were going there at all. And DHHS controls the referral process for this program. So we had no insight into this. It was not until December 2025 we received a breakdown that's been mentioned. I had the number at 37 total, but I think we can figure that out. Because Anthem's the largest commercial carrier, we agreed to take the lead on re-engaging with the CMEs to explore network participation. I think that's a good faith, non-legislative solution. I have other comments on the actual bill itself. I'm going to skip ahead. I want to say we are actively engaged with the CMEs on whether network participation makes sense. Contracting does take time, particularly with entities that have no history of working with commercial insurance. We have legal and regulatory obligations to ensure providers are qualified, services are clinically appropriate, and programs meet our internal standards. These safeguards exist to protect our members. And just because the process cannot, and frankly should not, happen overnight does not mean progress is not being made. We are committed to finding a path forward. I think this legislation would disrupt the collaboration and the work that we are doing towards solutions. So for these reasons, we respectfully urge you to find SB 498 inexpedient to legislate. Thank you for the time. Happy to take any questions.
All right, take a breath. So we've heard from a lot of people on both sides of this, and I think there is a desire to do something here. And from what I'm gathering and from what I'm just to summarize what you're saying is that, and I know you and I have spoken about this, and I know you are working along this pathway, but it sounds like right now there is the hang up, if you will, is, correct me if I'm wrong, but and I'm talking about functionally here. I mean, we all have heard the stories, and I think we all can relate to at least some of those in a variety of issues. But what I'm hearing is the CMEs are either not contracted, don't have a history of contracting. If they are, you would be happy to work on a solution outside of legislation, and that's where we're at right now. And I'm hearing that Anthem is taking the lead. And I don't envy that position, as I know this is a tough issue. So where are we at as far as an ETA? Do we have an ETA? Do we have some type of trajectory where we can say, you know, when is this going to get done? When are we going to have some resolution? When are we going to, you know, because we heard from the departments that there is a need. That's what I'm taking away from that. So we're, you know, giving you the latitude to not do something within legislation. When can we expect you to come back and say, we got something?
Thank you for the question. It's a good question. I have been in touch, and I couldn't fit it in there, but I did want to just express my appreciation to the CMEs and DHHS. We've been working closely with them, and it's been collaborative. These have been very good discussions. So I wanted to get that in there. As I told DHHS, it is really hard to put a firm date on something. And I just want to back up and say, I'm the messenger here. I don't work on our contracting team. I have engaged our vice president of contracting for the state of New Hampshire. I've engaged our whole local clinical team. So it's our medical director, BH clinical folks. I have the local team involved. And these people are moving as quickly as possible. They understand the importance. But these processes take probably normally 3 to 6 months with entities who are used to dealing with commercial insurance. So if we're bringing a new provider in, usually they have contracted before. We are starting at ground zero, and that's not a criticism of the CMEs. Just historically, they mostly have dealt with Medicaid or just DHHS. And so I told DHHS recently I would put us sort of in the middle of that process. I am meeting internally tomorrow with our clinical folks to really do a deep dive on the program. We think there's things we already do cover. So we want to figure out, what do we already cover? What are some things that might be challenging to cover? Maybe because of a provider credentialing issue or some other complication. So that's where we're really going to drill down. Then we would go back to the CMEs and say, do you have answers to these questions? It's really a back and forth. Then we have to move into the part of the process talking about, can we cover these as a bundled service? I don't know if we can, but I did say to DHHS, we are committed to trying to find other arrangements for funding if needed. So we haven't been able to make any firm promises, but my promise has been that we are working in good faith, and I have been very open to trying to figure out alternatives to help figure out the situation. I just want to say we have, I think, approximately 30 kids with Anthem, I think. That was the data from July to November. So we cover tens of thousands of lives in New Hampshire. So it's not a big number. That's not to diminish the importance of them, but I'm just saying that to suggest that I think we can figure out how to cover and fund the services for those kids. Sorry, that was a long answer.
No, thank you. Senator Abard.
Thank you. I was just kind of going over what the commissioner said. It's kind of like he's similar, agreeing with you that there's negotiations going on. We heard about an amendment that we have not seen yet. Are you part of that conversation with the amendments?
Thank you for the question. I was part of the conversation with DHHS and the CMEs and some of the other carriers a few months ago where we first learned about a proposal from the insurance department. We did give some feedback on it. I think there's some operational challenges with it, but we were not opposed to, and currently are not opposed to, trying to work forward on an amendment.
Senator Prentice.
Thank you, Chair Rochford, and Sabrina. Thank you for, you've actually, the question I was going to ask was, have you, I wanted to talk about the amendment or get some feedback, and we haven't seen it. Senator Abar just asked you, so I think we have an idea. It's hard to comment on something that you've heard about, but you have to have it in your hands. So that was really my question, but I was going to just make a statement before that, which is, I feel like we've been here before in talking about contracting and getting people in network, and I have a level of faith based on my previous experience that we've been able to get there. Now, we did have to get there within legislation versus outside of legislation, but I have a level of optimism based on how everyone's worked together in the past. You share that? Do you share that level of optimism?
Thank you for the question. I do share that level of optimism, and I really do think that now that we understand the members and the issues better, I truly don't think there's a need for legislation, a bill, or an amendment. I think that we have established that we are working collaboratively with the parties who run the program. So I have a lot of faith right now. I'm not a betting person, but if I was to bet, I would bet that we come up with, whether it's a sort of normal contract or some other arrangement that makes sense for the CMEs and us. I have a lot of faith that we will get there. We are currently on the path to that.
Quick follow-up. So I want to talk a little bit about parity here, and because this has been part of the discussion today. In this, I think I was talking to the Department of Insurance when I first brought this up. There is coverage. It seems like this is unique when we're talking about, say, I want to parse this carefully. We have mental health services and behavioral health services, and that are, say, covered and not covered. And this has to do with the entities that are in the CMEs that are coming into this that have not normally been in the past. But then, from a commercial health insurance perspective, you're covering, other, say, physical and medical conditions. And there seems to be a split in this, where over here, we're like, say, 100%, and here, we're maybe 70%. In your discussions, if I'm hearing you correctly, you've identified with the CMEs the services that are, say, in that 30%. Okay, and is in your negotiations and work, are you looking to cover those to bring some parity between these two? Is that fair? I mean, I kind of went the long way in, but I'm also trying to understand why these aren't exactly the same. And I think it might be the CME piece of this, not saying that that's bad or wrong, it's just the delivery model. Can you help me with that?
Thank you for the question. I think if I'm understanding, you're trying to get at maybe the like slice of the pie that we don't currently cover, those types of services that we would consider maybe not necessarily clinical. Is that what you're asking about?
Correct.
Yeah. So that came up in the CMHC bill as well. And so I think this is where my clinical team comes in. We have moved, commercial insurance in general has moved very close to sort of being fully 100% of what Medicaid covers. We're not there, but we are two different entities. I mean, Medicaid is designed for a different population and different services, and health insurance just historically has not covered things that weren't clinical. Again, that's not a knock on the services themselves. It's just a fact that certain things are not clinical. But I do think we are discussing those things, and I can't sit here and say, you know, we would cover 100% of that 30% or that slice of the pie, but we would like to figure out ways that we can cover them perhaps under existing codes, or I'd use peer-to-peer, for example. I often hear that's not covered. We actually do cover peer-to-peer support services. It's just, it's usually part of other services and it's coded as a bundle. And so it may be that we don't cover peer-to-peer as a standalone service. You get into issues of who's providing that? Are they licensed? How do we possibly credential them? I mean, there's standards that we have that are in state and federal law and our own internal standards we have to follow. And so a lot of it does come down to, it's not a judgment on the service. It's actually a practical issue. It's an operational issue. And so I just want to be clear about that, because I think often it's cast as like, we don't think these things are worth it. That's not true. So hopefully that is helpful.
It is. Thank you.
All right, thank you. So you are the messenger.
I am the messenger, and
You've got the message.
You have my promise. The thing I can promise is that I will message. It may not be what people.
I know you will. I know you will. And I know you don't make the decisions,
Yeah.
but you message to the people that do. And, you know, I think that there's not one person here that ever wants to see a mom come in and talk about the loss of a child and have to relive that
agree.
publicly. So that's
Yep.
the message. And bring that up to the folks and
We
let's get
understand
this
it. Yeah.
fixed. Thank you. Chair calls Cam Lapine and Margaret Reynolds.
Good afternoon, Mr. Chairman, members of the committee. For the record, I am Cam Lapine. I work at Orin Reno, here today representing Cigna. With me is Margaret Reynolds, the Government Affairs Senior Director at Cigna. I don't want to take too much of our 3 minutes away from Margaret because she is our expert. I do just want to, so you heard from Anthem that as of the data that DHS provided to all of the carriers at our meeting in December, Anthem had about 30 children in the Fast Forward program connected to them. The data connected to Cigna with about 4, showing the you know, difference of there are different ways to address 30 kids versus 4 kids. But now I'm going to turn it over to Margaret to speak to the bill.
So I am letting Sabrina take the lead, admittedly. But I just wanted to speak today to some of the operational aspects of the bill for your consideration, and should an amendment come forward, just to keep in mind. This bill creates a new association that would levy assessments. We would ask you to think about those assessments being limited to children based on their carrier, and certainly to lives situs or to plans situs in New Hampshire. There's plenty of children that are covered in the state by neighboring states and plans from those states. We would ask that any hiring contracts that this association might have in excess of $10,000 would go before the Executive Council for approval. And that any excess assessment dollars that this association has should go back to the carriers. So anything that's in excess of what they might need should go back to those who pay for those assessments. Lastly, I would just ask you to consider the effective date. Currently it's 60 days after passage, but given that it would need to establish a new association and that association to levy assessments, we might need a little bit more lead time on that. But just those are for your consideration as a committee, both for this bill and any amendment that may come forward. the rest of my testimony is written, so.
Thank you very much. Any questions from the committee? Senator Prentice.
Thank you, Chair Rushford, Margaret, Cam, thank you, good to see you again. So you brought up the amendment, and my question is consistent with the previous question to Sabrina Dunlap. We don't have it in our hands yet, but from what you've heard, what's your, not necessarily your position, but your perception of where, is this something that sounding like you can work with that?
Yeah, thank you, Senator Prentice. So our involvement with the amendment, much as Sabrina laid out, was in early December. We all sat together. We looked at a framework of an amendment. There was not formal language, as I recall. I'd not seen a draft. What I recall aligned with what the insurance department presented earlier, broad strokes, trying to incentivize billing, coming into network, data collection, figuring out, they kept using the word delta, that's the word that stuck in my head, and going from there. And we had some operational concerns with taking that framework and putting into practice as it was presented, but we were happy to continue discussions, but we weren't, at least I personally was not privy to anything following that.
And we're hopeful that we could also, similar to Anthem, work with these providers to address the concern without legislation.
Which is part of, now that I've put my brain back in my head, the reason I brought up 4 children versus closer to 30 is with 4 children, perhaps coming into contract a formal contract doesn't make sense, but a single case agreement for individual children, which might work better with a bundled payment model, might work better. And that's just a conversation that hasn't happened between the CMEs and carriers in the past. So that's another opportunity for a non-legislative solution.
Any further questions from the committee?
Good, thank you.
So just to make it clear, you got 4 kids that you would identify that would be covered by this.
So the data that DHHS provided to us at our meeting in December was that they had identified 4 children connected with Cigna involved in the Fast Forward program.
Right. Why not just pay for it? 4 kids.
So that gets
4 kids.
I respect that, Senator. To the point that Sabrina raised, if the CMEs are not billing, we cannot pay. That's how insurance works. We can't.
All right.
There has to be an exchange.
Fair enough. I'll give you that one.
Thank you, Senator.
Any other questions? Thank you very much.
Thank you.
Peter Bragdon. Good afternoon.
Good afternoon, Mr. Chairman, members of the committee. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, who, as you know, is the state's not-for-profit health insurance company, providing insurance coverage for over 40,000 of our friends and neighbors. And a few things to say just in advance. I think I appreciate the work that Deputy Commissioner Henn has done and her staff, as well as Commissioner Betancourt, in getting people together. Because prior to December, this thing had been kicked around for a long time and there really wasn't any good data to work with. And so the numbers you're hearing today, 30 kids with Anthem, 4 with Cigna, Harvard Pilgrim Healthcare, we've been told by DHHS that at least as of then, there were 4 children with Harvard Pilgrim Healthcare coverage that are involved in the Fast Forward program. And I think to answer Senator Rocheford's question to the prior speaker, why not just pay for it? That goes back to it's a matter of being in the network. And a couple of years ago, the insurance commissioner directed us to reach out to the 2 CMEs that provide the Fast Forward services to come in network. One never returned calls or emails. The second one said, no, we're not interested. And so there has to be a contractual arrangement there to get this done. I will say that I believe the contracts that the CMEs have with DHHS requires them to send bills to insurance companies. And all the time, we've never received those bills. So prior to December, we really had no visibility as to what was going on in the scope and scale. So we've got some good data. I think that problem's been much better identified. I appreciate the work that Anthem is doing to try and bore down to this. I am optimistic that some agreement can be reached. Non-legislative, I do think there's a number of problems with the bill as it stands. I think the amendment from the department that we saw and commented on back in December, at least as a better alternative rather than set up a tax structure. But it's possible this can be resolved through a non-legislative solution. If the bill were to move forward, though, we have a specific concern about Section 3 of the bill, which has never been discussed. That sets up a whole broad, expansive filing. It's on page 7 of the bill. Currently under federal law, there's reporting that has to be done in filings that has to be done with the state, detailing the mental health parity. And Section 3 of the bill significantly expands that, requires breakdowns and separate reporting of 3 different issues, which is a tremendous amount of work for, we're not sure what the value is, it's never been talked about. I will say that the Department of Insurance has broad authority in the regulation of the Federal Mental Health Parity Act to determine what needs to be reported. And I think this new Section 3, again, in part because it's never been discussed, it's just a big black hole, and we'd like to see that taken out to provide further opportunity down the road to figure out what exactly it is.
I'm going to interrupt you because we don't have a page 7 and I don't see a Section 3.
Well, that's a problem then, isn't it?
Perfect timing.
That's funny. I have a page. I have a page. Oh, I thought I had a page 7. Son of a gun. I have a page 6. So page 6, basically the last thing before the effective date. I'm sorry.
Okay. All right. Thank you.
Oh, you know, I was, dagnabbit, I almost said a bad word. On your PDF viewers, the cover page counts as page 1.
Oh,
so
right.
it told me page 7, it's really page 6.
So while I was hunting for that, my mind was.
Yeah, I know.
So
I
can
could
you
see you were
repeat that
hunting.
again?
So the federal healthcare law provides for, mental health parity law provides for reporting to the state, which is that first sentence you see there that's not in bold. Section 3 adds all that bold language, which basically is tripling the amount of reporting that has to be done, dividing it up into categories of ages, and we're not really sure why. The department has broad authority to tell us they want more data or not. And then secondly, when you divide up data into such small segments, sometimes you get data that's, the sample size is so small, it becomes irrelevant, or you're comparing a small sample set to a big one. Like I said, we only have 4 children in this program. So when you start dividing up things so small, the data really becomes meaningless. So without a better description of what the intent is there, we think this is better to be carved out and deal with it as a standalone later on. So, and those are my general thoughts on the matter. I think it's something that can be done, but we have to get to network arrangements with the CMEs. And they've been certainly cooperative in this whole process, just saying that before this, we really had no visibility into it. So,
Sure. Any questions? So my takeaway is the CMEs call you, you're going to pick up the phone, you're going to get them in network, and you're going to pay for these 4 kids.
We're definitely going to work with them to get them in the network.
All right. You're smarter than to agree with that. Thank you.
Thank you.
The chair calls Michelle Merritt.
All right. Thank you, Mr. Chair, honorable committee members. My name is Michelle Merritt. I am the president at New Futures, and I am here today in strong support of Senate Bill 498. I don't want to repeat testimony that has already been heard. I think you have a fair understanding of the importance of Fast Forward as a program. I have been personally working on this particular issue since February of 2021. At that time, there were 51 kids boarding in hospital emergency rooms on a single day in February. And currently we have a handful of kids. And why is that? It's because of programs like Fast Forward. So I also want to address a couple of other things that have come up from testimony. First and foremost, again, we've been working on this for 5 years. Progress on this issue has been painfully slow. We have tried non-legislative solutions. The Department of Insurance, to their credit, has been involved for years trying to get us to this place of getting these services covered for kids that need them, that are privately insured, and yet we still have no commitment from the carriers to pay for this as a bundled service, and you just heard it reiterated again. I also want to clarify that no carriers are paying for Fast Forward or high fidelity wraparound in the state of New Hampshire right now. They're just not paying for it. If the CMEs don't bill, we can't pay. I heard that from a previous speaker, and I just want to also reiterate the point that there's no claims data because the carriers refuse to cover the service. The CMEs can't submit bills because they don't have contracts. The irony here is almost unspeakable. To ask the CMEs to produce something, but then also not actually engage in any contracting or provide them mechanisms to bill for the service is ridiculous. We've also heard that the CMEs have been unresponsive. And again, we've worked on this together for at least 2 years at this point, and that could not be further from the truth. I would encourage you to bring them back up and have them talk about it. There's lists and documents and pages upon pages of emails where all they have tried to do is follow up and do everything that they needed to do to address this issue. So you can't refuse to cover a service and then force a taxpayer to pay and then complain that you don't have data. I also want to take a little bit of my time to talk about the amendment, which I also have not seen, and to address some technical questions about it. So the amendment that I understand is talking about a qualified payment amount for these services. And it is not something that we are currently believing is a reasonable solution to the problem at hand. And that's for a couple of reasons. One is the suggestion of a qualified payment amount only applies to the fully insured market. It does not apply to the self-funded plans. So that $2.5 million that we've been talking about annually that goes to subsidize kids with private insurance to access Fast Forward, we would still need some of those funds to reimburse for the care of those kids. I also want to just reiterate that the assessment is unique because it captures all kids, all payers. It equitably distributes the responsibility to pay into it among all the carriers, something that you can't do with a QPA. I also want to address the last point, and I heard it come up previously, and that's that these
Briefly, if you could.
briefly, yeah, I will. That, and this came up last session, that the opponents of the bill labeled this as a carrier assessment as a tax. So again, let's address that head on. These services are already being paid for by a tax. The general fund is entirely comprised of taxpayer dollars. So the policy question before this committee is not whether a tax should support this program. The question is who should be paying it. And should it be the New Hampshire taxpayer subsidizing private carriers, or should it be the carriers taking financial responsibility for the services their own members are using? We argue that the answer to that question is painfully obvious. Of course, it needs to be the carriers. And so I leave you with that, and I'm happy to answer any questions about the assessment, any type of amendments. Again, we have not seen it, but I urge you to listen to the advocates, listen to the families who have just poured their hearts out and told you how important this service is and how at risk it is for potentially going away or being underfunded. So I'll leave you with that.
Thank you. Are there any questions from the committee? Thank you very much.
Thank you.
Is there anyone else that would like to speak on Senate Bill 498? And with that, I'm going to close the hearing.
Whenever we get
I would. I'm going to open the hearing on Senate Bill 474 relative to the effective date of the law regarding collection and reporting of abortion statistics. I'll ask Senator Birdsall to introduce her bill.
Thank you, Mr. Chair. Thank you, committee, for hearing my bill. I am the prime sponsor of Senate Bill 474. For the record, my name is Regina Birdsall, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And for the record, yeah, I already said all that. I'm the prime sponsor of Senate Bill 474, being made at the request of the Department of Health and Human Services. It is 474 is relative to the effective date of the law regarding the collection and reporting of abortion statistics, and it seeks to amend House Bill 712, Chapter 28, 287:15, which reflects the Committee of Conferees agreement to have the section of the bill effective July 1st, 2027, rather than the Scrivener's error of January 1st, 2027 in the final version of the legislation. The change is needed to address implementation costs of approximately $948,000 to stand up the program to be addressed in the 28 to 29 biennial state operating budget. But as you'll recall, the Senate concurred with related Senate Bill 36 as amended by the House at last Thursday's session. Department staff Abby Rogers and legislative liaison for the department, John Williams, is in the audience, and they will go through a little bit of it.
Great. Thank you, Senator. Any questions? Thank you very much.
Thank you.
Chair calls John Williams.
Chairman Rocher, members of the committee, being that all of the Senate conferees that were there that agreed upon the effective date of July 1st of 2027, want to thank you again for bringing forward this particular bill, Senate Bill 474, to ensure that we can time standing up the new abortion statistics reporting program with the appropriations that are needed. So our plan is to do that as part of the operating budget for the next biennium. With that said, you did concur on another bill, the actual underlying bill that establishes that particular reporting requirement did pass the House, and they did adjust the date at the department's request to the July 1st, 2027 date. And the only reason I'm holding you between now and lunch, which you need to deserve having a really good lunch, is to explain why we still need to keep this bill in play. In November, when the retained bill was acted upon by the House Health, Human Services, and Elderly Affairs Committee, they did honor the department's request to extending and mirroring the exact date that you'll see in this bill. So in that sense, those two bills are identical. However, where they are different is that the House took it upon themselves without, and again, I'm just putting out there was no full public hearing, but there was an amendment to the bill that was going to amend RSA 329:14-A Roman 1F. And it's important to note that they struck the word estimated from the following sentence in that provision. Estimated was struck, estimated gestational age when the abortion was performed. So you can see from a provider standpoint, by taking the word estimated out, that not the department, but the provider community may have some issues relative to what is necessary clinically then to appropriately identify the gestational age of that child. So knowing that the Senate and House have passed it and it's going through the enrollment process and heading to the governor's office, I just wanted to make sure that this was still in play in case there was others out there that might want to express their interest to the corner office between now and then. So if the plan is to table this, and as long as we can get it off the table, knowing what the governor's action is going to be on 36, would direct whether or not we need to keep this thing moving along.
Great, thank you. Any questions? Is there anyone else that would like to speak on Senate Bill 474? With that, I'm going to close the hearing. And we will break for lunch, and it's been a long morning. We'll be back here at, what do you think, 1:15? Oh, we're scheduled at 1.
Yeah.
Open up at 1 and recess.
Well, then we have to be here anyway, so.
I definitely have a time at one. You wanna, right now, accept the copy, Bill? Or you all set?
Oh, I'm hungry. What do you mean?
We're hungry.
You have to write it down.
Wait.
Recess until 1 o'clock.
All right.
All right, welcome back. So we didn't leave. We're going to open the hearing on Senate Bill 455 relative to health plan coverage of GLP-1 medications. I'm going to open the hearing and ask Senator Prentice to introduce her bill.
Good afternoon, Chair Rochford and members of the Senate Health and Human Services Committee. For the record, my name is Sue Prentice. I'm the State Senator from District 5, representing 15 communities from the Upper Valley, part of Sullivan County, as well as one in Merrimack County, the beautiful community of New London. I'm here today to introduce Senate Bill 455, and the version that I introduced now has a replace all amendment, and I'm going to talk about that, but this is still about GLP-1 coverage. And I have taken a different policy shift to talk about GLP-1 coverage through the Medicaid program first, and then having a later conversation, which was my initial plan for the commercial health insurance carriers. But the reason to do this is exactly the same. So just for level setting, GLP-1s, it regulates blood sugar and appetite, and it also works with weight loss by mimicking a natural hormone in your body. So that's what it is. We hear there's different names: Trizepatide, Zepbound, Ozempic. You know, we're actually seeing what's available grow, which will be good for driving down prices and be part of my overall argument in terms of the cost projections for these pharmaceuticals. But I just wanted to lay that on the table. So it's mimicking a hormone. That these medications are, I believe, at the center of Medicaid policy discussions across the country because they sit at an intersection of cost, medical necessity, and long-term fiscal responsibility. First, what we do know is that the science is clear that medications that improve blood sugar control, support significant weight loss, and reduce risk of cardiovascular disease, kidney disease, and disability. These are not marginal benefits. They directly affect the conditions that drive Medicaid spending. So I'm once again taking an approach that will have a long-term cost benefit by treating obesity. And it's important to note that this is not a cosmetic conversation. This is about a medical diagnosis where when we treat obesity, we are treating also, we're not just treating, but we are preventing other medical conditions that are very costly. And one that I often talk about is diabetes and what the cost of those are, what the cost of that is to New Hampshire. And I'll get there. But thirdly, these cost concerns are real, but they must be viewed honestly. The average cost of advanced diabetes care, dialysis, amputations, and long-term disability far exceeds the early evidence-based interventions. Medicaid already pays for end-stage disease. So the question is whether we're willing to shift this and pay less earlier rather than paying much more later. And I recognize as I'm, introducing this and shifting, from one policy to, well, the policy discussion is the same, but the coverage discussion is changing, that this medicine and the science is evolving every single day around us. And that when we're sitting here next year having a similar discussion, I think the market is going to be different in terms of prices than it is right now. And I also think that there's an equity issue. Without Medicaid coverage, GLP-1 medications are effectively available to only people with a commercial insurance plan that is generous, because not all of the plans are covering this for obesity care, or the ability to pay out of pocket. So that creates a system that's two-tiered. And it's been made recently more cost effective, but still folks that are on Medicaid, that extra, it could be $400, $500, $600 a month is not available to them. And if they don't have this to treat their underlying conditions, then we're going to see exceedingly higher, I believe, higher costs in the end. So finally, this is not about unlimited access or lack of oversight. Coverage can and should be tied to a clear body mass index and comorbidity criteria. So comorbidity is just saying other medical conditions, and they are listed out in here. Again, noting some of which are already covered, but this is a belt and suspenders approach. Prior authorization still has to be there. Ongoing medical supervision by their care provider still has to be there, and demonstrated clinical benefits. In short, GLP-1 medications are controversial, not because they are ineffective, but because they challenge us to modernize Medicaid policy in light of current medical evidence. The debate about prevention versus reaction, short-term budgets versus long-term costs, and whether Medicaid will reflect modern medicine and remain in a place rather, moving forward versus, and this is adopting or staying with outdated policy frameworks. Now, I'm clear that the position of staying with outdated policy frameworks is tied to funding that has been cut from the department, and so choices have had to be made. I'm sensitive to that, but I think that we're actually going to put the department in a better position by focusing on this. And I know there are folks on the department here. In the bill, it does clearly outline body mass indexes that are aligned with obesity treatment and certain medical conditions that we're going to work, that if they have one of them, we can actually minimize it, and maybe, by minimizing it and putting preventative strategies in place, it won't cost the state so much. I wanted to give you a list, and so list prices, if we are talking about these medications, can be somewhere between $12,000 and $15,000 a year. But when we're talking about, for comparison, dialysis for kidney disease, $90,000 a patient per year. Lower limb amputations, which are tied, unfortunately, to the progression of diabetes, $70,000 to $100,000 initial year. Poorly controlled diabetes, which is an underlying problem that affects all of these comorbidities, of these medical conditions that I've talked about, $15,000 to $25,000 per year. That's per patient, and we can get into looking at what it costs the state in terms of $1.2 to $1.4 million. And heart attack or stroke, $20,000 to $40,000. So I'm putting those in place for comparison, again, to strike the balance between a preventative strategy versus a reactive strategy. And with that, I'll close my comments. I'm happy to take any questions you might have that I can answer.
Senator Birdsall has a question.
Thank you. Thank you for taking my question. Did you talk to HHS before you put in?
I did. Yeah, I had talked to HHS maybe well over a month ago to get a number of how many patients could potentially, that are being, that are on Medicaid now, looking at Medicaid expansion, could be impacted. And then I said, because I was proposing changing this, putting this replace all amendment in, and I did talk to Henry Lippman yesterday because we had been waiting to hear back, and the department has been very helpful, but I needed to get language on the table. So this is where we are, and I let him know that this is what I'd be introducing today.
Thank you.
Any other questions? I've got a quick question. So looking at your amendment, it looks like you actually widened the criteria for it. And looking at the fiscal note, are we going to get a revised fiscal note?
We're going to need a revised, sorry.
Yeah. No, you answered my question. So I just want to make sure we're getting that, because that'll be helpful.
Yeah, so I did, my first pass when I was talking about, and I will be, I'm committing to moving forward with the commercial plans at a later date, maybe next year, when again, we see this evolving medicine and costs. These costs, I believe they already are going down, and we're in a better position to support this. I moved away from an approach that was more on the brink of surgical care and moved to strictly looking at the obesity diagnosis, what makes up an obesity diagnosis, and what other underlying medical conditions we can actually work to prevent or control in terms of care.
Thank you. I do have some cost questions, but I am going to save that for the department.
Okay.
Thank you.
Thank you very much.
All right. And with that, I'm going to call up Rob Barry and Peg Clifford.
Good afternoon, Mr. Chairman and members of the committee. Rob Berry, I'm the General Counsel to the Division of Medicaid, and with me is
Margaret Clifford. I do go by Peg. I'm the Pharmacy Director for New Hampshire Medicaid.
Good to see you.
Good to see you.
So we're here just to provide information. We're a little late to the game, but we do appreciate the sponsor contacting Director Levin yesterday to let us know that she would be filing the amendment. I'm not here with any solid numbers today, but we do anticipate getting a fiscal note worksheet request from the LBA should the committee adopt the amendment and moving forward with it. But we are happy to take any questions you have. To the extent we can answer them, we will answer now, and to the extent we can't, we will put them in the queue.
And the question I have goes around, I think maybe 2 months ago, we heard from Washington that no one's going to pay more than $150 for these drugs. You know, it's they're going to get the best deal in the world. I've yet to see how that plays out, and I've yet to see how that would affect Medicaid programs. So do we have any more details on, are we really going to get the oral drugs for $149 a month and the injectable drugs for that cheap? I mean, I think that would significantly change the scope and breadth of the bill. But as we all know, things that are sometimes talked in DC have a hard time, maybe never translate to the states. So I guess that's really where I'm looking for. What, is that on? When is it going to happen? Is it going to happen? Are Medicaid programs going to be able to get those prices? Are private payers going to be able to get those prices? So any type of insight or information on that, I think, would be very helpful to the committee.
Yeah, we don't have any details on the pricing yet, but I did want to clarify that Medicaid does currently pay for GLP-1s for diabetes, and we pay for anybody that is overweight with a BMI of 27 that has comorbid conditions that can lead to MACE, MASH, or anyone with a BMI of 27 that has obstructive sleep apnea if they meet our prior authorization criteria. So the only thing we don't currently pay for is when it's prescribed solely for weight loss. But these other conditions are already covered with the exception of osteoarthritis. None of the GLP-1s are currently FDA approved for osteoarthritis, and Medicaid, we have to follow labeled indications. And so, and we are required to pay for, there are certain things that are excluded from coverage. Weight loss is one of those that is an excluded coverage. So that's why we currently exclude solely weight loss, but we do cover for the, MACE, MASH, and obstructive sleep apnea, and diabetes has been covered. And all of our prior authorization criteria is available on the department's pharmacy website.
Okay, thank you. That's helpful. Senator Bertzel.
Thank you. So, and thank you for taking my question. So it looks like, since you cover most of the conditions from on line 17 to 23, I think, of the amendment.
We don't actually have a copy of the amendment in front of us. Okay. Yeah, I'm working off the introduced bill. Thank you.
So it sounds like you cover type 2 diabetes, hypertension. I'm not even going to try that one. Obstructive, what? Dyslipidemia. Obstructive sleep apnea, cardiovascular disease, pre-diabetes, and metabolic dysfunction.
Yeah,
So
that's MASH.
So you cover all of that, but it's in A and B that would be the difference, because that would be greater than or equal to BMI of 30 kilograms.
So B, we cover the BMI equal to or greater than 27 with at least one weight-related comorbidity. So that is currently covered. It's just solely for weight loss is what is not covered, with the exception of children under EPSDT.
Okay. So Then in line 24, where it says DHHS shall submit to CMS any amendment, so they already cover most, they're already apparently approved for most of that, so you would just need to request a approval of weight loss?
Yeah. We used to cover it for weight loss in our state plan. I think the state plan just lists coverage, so we didn't have to change the state plan when we changed the coverage criteria, which happened on January 1st for solely weight loss. So I don't think we actually would need a state plan amendment. I think our current state plan covers it.
Okay, thank you.
Any other questions from the
I have one,
committee?
but I think Senator Long, did you? Yeah.
No, Senator Prentice.
Thank you. And so thank you for testifying. So I added, A in lines 14 and 15, essentially 14 would be, a standalone or the second BMI, but by having the comorbidities, it, I think, makes it stricter. And it's not, when we talk about weight loss, it's really talking about obesity treatment, because I think what happens is we talk about weight loss, we start to think about the cosmetic piece. And I want to focus on the medical condition of obesity and what, contributes, what actually the underlying conditions that can be prevented by approaching and treating obesity in terms of a medical care perspective. Okay, thank you.
Thank you very much.
Thank you.
Sorry. Okay, the chair calls Charlotte Fager.
And Dara wasn't there. And what? Daryl and Sharon weren't there. We started late.
Welcome.
Thank you. Good afternoon, Mr. Chairman and committee members. My name is Dr. Charlotte Fager. I'm a primary care physician in Concord. I'm here on my own behalf in strong support of SB 455, which will expand the coverage for GLP-1 agonist meds for people with severe obesity and comorbidities. I care for patients every day with obesity and associated chronic disease, including hypertension, diabetes, sleep apnea, and heart disease. I've seen what GLP-1 medications can do. I think of a woman in her 50s with a BMI of 46 and severe knee arthritis. After 6 months on Wegovy, her BMI dropped significantly. She's exercising again. She's sleeping better. Her arthritis is better. She's less anxious. Her life has changed. I also think of a woman in her 40s with 3 jobs and severe obesity, high blood pressure, and sleep apnea. After months of healthy dieting and exercise, she started Mounjaro. She responded beautifully. Her blood pressure came down, her sleep improved, her weight decreased, until her insurance stopped covering the medication. The weight returned despite her persistent and continued effort. The only barrier to her improving health was the insurance coverage. Severe obesity, defined as BMI over 40, reduces life expectancy by up to 8 to 10 years. This is comparable to the effects of smoking. This is largely due to the development of cardiovascular disease. In 2020, nearly 8% of adults in New Hampshire had a BMI over 40. Obesity is widely accepted by clinicians as a chronic relapsing disease. It is not a lifestyle choice. We would never tell a patient with high blood pressure to simply try harder. We treat it, we cover the medications, we follow the science. We know weight loss improves outcomes. It lowers blood pressure, it improves diabetes control, it reduces sleep apnea, and it lowers cardiovascular risk. But meaningful weight loss is extraordinarily difficult to achieve and sustain with lifestyle changes alone. To lower systolic blood pressure by 15 points, a patient might need to lose up to 30 pounds. To reduce an HbA1c from 9% to goal, a patient might need to lose 40 to 45 pounds. As I'm sure many of us in this room know, that is an enormous burden to place solely on willpower. This bill does not mandate treatment or eliminate clinical judgment. It just ensures that the decision about whether to treat obesity as the chronic disease that it is remains between patients and their physicians. Thank you for your time and consideration, and I'm open to any questions.
Senator Bertzel.
Thank you, Mr. Chair. Thank you for taking my question. The question I had, and I've heard the pros and the yes and no on this. If you're on a GLP, regardless of what the reason is, and you lose the weight, do you have to continue on that for the rest of your life, or is there a period that you can wean off of it or reduce the amount?
Yeah, you do not necessarily need to stay on it for the rest of your life. Of course, it depends when you start and what you're on it for. But generally, the plan going in is to get to a goal, whether that's, a blood pressure goal or a weight goal or a diabetes goal, and then to start weaning off. Sort of what we practice in primary care is establishing those habits while you're on the GLP-1 agonist to maintain sustainable weight loss after you're off of it.
Any further questions? And I do have a follow-up on that line. It looks like the data is showing that unless you're changing lifestyle, unless you're, taking proactive, you do have to be on it forever to get the, substantial results. So I think one of the concerns in the society that we live in, it's a lot easier to take a shot or take a pill and lose the weight that way than take a shot, take a pill, change your lifestyle, change your diet, and then get off of it. I mean, that's just America, is it not?
Yeah, absolutely. And that's why I would argue it's kind of necessary because that is the country that we're living in. And, the people with 3 jobs who don't really have the time to completely overload, have a new lifestyle change.
So being that this is America, it's conceivable that this is something you're going to be on.
It's possible. Yep. It's definitely
For a
something we
long
need to
time.
be on for a long time.
All right. Thank you. Any further questions? No, thank you very much.
Thank you.
Cam Lapine and Margaret Reynolds.
Good afternoon, Mr. Chairman, members of the committee. For the record, I'm Cam Lapine. I work at Orrin Reno, here today representing Cigna with Margaret Reynolds, the Government Affairs Senior Director at Cigna. We are opposed to the bill as introduced. I am looking at the amendment now for the first time. On first glance, I believe we would be neutral with the amendment, with the bill if the amendment were adopted. Given Senator Prentice's comment about perhaps a future commercial mandate, there are just a few points we wanted to raise into the record. Before I hand it over to Margaret to hit some of the bigger picture items, I want to speak just from my personal experience. There are alternatives to GLP-1s on the market that are significantly less expensive. My BMI is higher than it probably should be, and part of that is because I'm 5'2".
There you go.
The BMI chart says I think I should weigh 120 pounds. If that happens, good for me. I went to my doctor and I asked, what about these GLP-1s? What do you think? Do you think they would work for me? And she said, maybe, you're young, but they're very expensive. Let's look at some other options. And what I realized, there are generic small molecule pills, such as phentermine and topiramate, which are 2 pills, you take them, and they're generic. They've been on the market since at least the 1950s. That when taken together, have essentially the same effect towards appetite suppressant and feeling full longer, satiety. My employer's self-funded plan does not cover those. So I said, oh God, what is this going to cost me? I went down to CVS and they cost me $20 and $30 out of pocket, which for me I can afford. I understand, for some people that may be. But that speaks to the alternatives on the market that perhaps a blanket GLP-1 mandate may not consider, especially in the group market where employers build specific drug benefit plans. So with that, Cam story time, we're going to hand it over to Margaret to hit on some other points.
Thanks. Hi again, Margaret Reynolds from Cigna. Just wanted to hit on a few items. One, we appreciate the amendment. As Cam said, we would be neutral if that were to be adopted. But to the original bill, Cigna does offer a GLP-1 program to our employer-sponsored plans who choose to do it. There's a PMPM cost to it. But in addition to access to the drug, the member also has to commit to a behavioral and lifestyle modification program. We've seen longer success with those modifications and the drug. So we would just put that in front of the committee to consider. The prescription drug alone is not going to solve all of this. But we will share, and it's also in the testimony, we've seen per member per month premium impact for these drugs anywhere from $14 to $30. So something to consider in the commercial market. If the original bill were to go forward, we would ask that it's limited to the fully insured market. But if this amendment were to go on, perhaps we can study the actual realized cost by the state before putting a mandate out into the broader market. The last point I just want to share, the North Carolina State Health Plan did do a GLP-1 mandate. They offered it to their members. They saw costs exceeding $100 million in the first year. So then they took that off for the state employee plan. It is now back very restricted. It's a BMI of 38 or higher, and they've only allocated $25 million a year to cover that. So we'll see how it plays out in North Carolina, but that's just another case study to consider as this moves forward.
So I know the amendment, what it does, and kind of carves you out of it, but this is a little aside. So you heard my question to DHHS about the big promises from DC that no one's going to pay more than $150. Are you seeing that pricing in your contracting through rebates, et cetera?
Not yet. I will say Cigna and Express Scripts is moving toward a rebate-free model for our fully insured products at the start of next plan year. So I could have more to report next year about what we're seeing, but I don't have anything at this time.
Great, thank you. Are any questions? No, seeing none, thank you very much. So is there anyone else that'd like to speak on Senate Bill 455? With that, we're going to close the hearing. Last one. And then we'll
move into exec.
Oh, no, we did. Okay, I'm going to open the hearing on Senate Bill 501 relative to authorization of seclusion or restraint during a personal safety emergency by a physician, physician associate, or advanced practice registered nurse. I'm going to open the hearing and ask Senator Prentice to introduce her bill.
Good afternoon, Senator Rochford and members of the Senate Health and Human Services Committee. For the record, my name is Sue Prentice. I'm a state senator from District 5, representing 15 communities. Larger Upper Valley, part of Sullivan County, and the lovely community of New London in Merrimack County. So I'm here today to introduce Senate Bill 501. This is what I call like a technical bill that is going to assist with practice. And so let's just talk a little bit about this. This will allow the department, since this was at the request of the Department of Health and Human Services. Senate Bill 501 is relative to the authorization of seclusion or restraint during a personal safety emergency by a physician associate, or an advanced practice, an APRN, an advanced practice nurse, and physician, well, we are talking about physician associates, in addition to the physician. So what we're doing is seclusion is already authorized. It is, covered in New Hampshire. There are protocols in place for it, but we're broadening the group that can write these orders in an emergency. So what it'll do is it'll amend RSA 135 C57V, authorizing the APRNs and the physician associates, in addition to the physicians, to make these orders. Additionally, this legislation addresses any conflicts within state statutes, specifically RSA 151-21, Patient's Bill of Rights, and aligns this with federal law, which is 42 CFR 482.13. You have to love John Williams. Department staff and Attorney Rosemary Wyant, and Cindy Bebanos, the Chief of Community Integration Officer at New Hampshire Hospital, are here today to present and answer any questions on Senate Bill 501. And I would thank the committee members for letting me introduce this bill to improve care options and the number of care providers that are available to write these orders in a personal safety emergency in alignment with the current practice and law. Thank you.
Great. Thank you, Senator. Are there any questions for Senator Prentice? No, thank you very much. So the chair calls Jeffrey Fetter, Rosemary, she just told me, and Megan Thompson. I can't really read. The doctor probably signed in, right? Yeah. So you're the only one signed up to speak on this, and there's nobody in opposition. So we'll hear what you have to say.
Right. Well, thank you very much. And thank you, Senator Prentice, for your introduction. My name is Rosemary Wyant, and I am an attorney with DHHS, and I work with New Hampshire Hospital as general counsel. I am here today with my colleague,
Megan Thompson.
Oh, you got to turn the yep, there you go.
Thank you. Megan Thompson. I'm the Advanced Practice Provider Lead at New Hampshire Hospital.
Senator Prentice covered the high points, and this is a very straightforward bill. I would just like to reiterate a couple of items. And just a note for context, the bill pertains to both APRNs and physicians associates, both of which are considered licensed practitioners under CMS. My comments, however, will focus on APRNs because New Hampshire Hospital uses APRNs as treatment providers in the hospital. One other point, just for background, this bill concerns restraint and seclusion. And just for everyone's awareness, to the extent that you're not that familiar with this, seclusion and restraint are interventions sort of as of a last resort, if that's a good way to describe it. They are used when a patient is experiencing a personal safety emergency, and they're used to ensure the patient's physical safety and the physical safety of others around. So that, with that backdrop in mind, this bill very simply does three things. It allows APRNs to order restraint and seclusion when such an intervention is necessary, and APRNs at New Hampshire Hospital and the other DRFs in the mental health system use APRNs as the treating providers for many patients. Under current state law, these providers, though, must contact a physician to obtain an order for seclusion and restraint because the way 135C is currently written, only physicians may order seclusion or restraint. That physician that they contact, however, might not even know the patient that's in the throes of a personal safety emergency. The second thing is it brings state mental health law into alignment with federal law. CMS regulations and accrediting bodies such as the Joint Commission that accredits New Hampshire Hospital authorize both physicians and licensed practitioners to order restraint or seclusion during a safety emergency. And then finally, this bill eliminates potential conflict with other state law, specifically, as you mentioned, 151-21, the Patient's Bill of Rights, through the notwithstanding language at the beginning of the bill.
Great. Thank you. Are there any questions for the department? Thank you very much. Unless you had something else you want to say, Megan?
I think Megan does have she has some written testimony that she will submit.
You can send that to Sophie. Yeah.
Thank you.
Is anyone else would like to speak on Senate Bill 501?
Thank you.
With that, I'm going to close the hearing.
Motion to move into exec?
Let's make sure Sophie's ready. Well, I'll take the motion.
Yeah.
I have a motion. Do I have a second? All those in favor say aye.
Aye.
All right,
Yeah,
we're in
let's
executive
take
session.
our time. make a motion to pass on this? Well, we just
All right,
did.
yeah, let's do it. We give her this. She's gotta get set up. Okay, so Senator Avard moves ought to pass on Senate Bill 501. Do I have a second? He was on it. I'll let her take it out.
You want me to withdraw my motion?
I know, but I heard consent, take it out, wait, no.
No. I didn't go consent yet. I didn't go consent yet.
We have a-
Yes.
Discussion.
Any discussion on Senate Bill 501?
Thank you very much.
All right. So, you ready, Sophie? All those in favor of ought to pass on Senate Bill 501, say aye.
Aye.
Any opposed?
Consent?
Senator Avard moves consent. Senator Birdsell seconds. All those in favor say aye.
Aye.
Any opposed? And then Senator Prentice will take that one out.
I will, thank you very much.
Well, there's one.
Yeah, GLPs, we're gonna wait on that. I move ought to pass on Senate Bill 474. That was the abortion statistics. Senator Birdsell seconds that. Any discussion? So I'll call the question. All those in favor of ought to pass on Senate Bill 474, say aye.
Aye.
Any opposed? All right, we'll pass that.
Consent?
Senator Avard moves consent. I'll second that. Oh, wait, do we want?
If we want to table it.
Oh, yeah, well, not, yeah, we would.
I withdraw my yeah.
And Senator Birdsell will take that one out.
Please. Can I ask for reconsideration?
Yep,
I mean, I understand the process part of this, but I actually want to change my vote.
okay.
I mean, I
So,
know where we're going, but
yep.
Yep.
So,
motion to reconsider? Oh.
Yes.
yes, she was on the, yeah.
Aye.
So the question is motion to reconsider. All those in favor to reconsider, say aye.
Aye.
Any opposed? So the motion to reconsider, the motion now is ought to pass.
Second.
So all those in favor say aye.
Aye.
Any opposed? 3-2. And Senator Birdsell will take that one out. Let's see. Hold on to that one. Senate Bill 452, healthcare providers to offer certain complementary and alternative healthcare service. That was the one we heard earlier today. 452,
I would move interim study.
and I would second that.
452.
Yep, 452. Motion is interim study. Any further discussion?
Yeah, that I would prefer either interim study or ITL. I think that,
Soft blow.
there's a lot more to know about this, and
Yep.
that's all to say, yeah. Okay.
So the motion is interim studies. Any further discussion? All those in favor say aye.
Aye. Aye.
Any opposed? I'll move consent.
Second.
And Senator Avard seconds that. All those in favor say aye.
Aye. Aye.
Any opposed? And I can take that out. Let's see. Let's hold off on that. One. Senate Bill 550.
Which is?
Insurance coverage for services provided by naturopathy providers. I'm gonna move ought to pass.
the second for discussion?
550. So we've got a motion and a second from Senator Abard. Yeah, if I'm going too fast, Sophie, you let me know. All right.
For me right now, but I will get into the groove, sorry.
That sounds like a song.
I know. 550, I know.
What was the motion?
The motion was ought to pass.
Yeah, okay. Yes. We have a second for that? I'm
Yes.
sorry, then Rochford. Okay, good.
Any further discussion? All those in favor say aye.
Aye.
Any opposed? I'll move consent.
Second.
Consent, Senator Rochefort, Senator Birdsell seconds. All those in favor say aye.
Aye.
Any opposed? And I'll take that out. There is an FN on that. A little one.
There isn't a little one.
So,
606, is that in there?
606. Which one is that?
Biomarkers.
Oh, yeah, let's do that one. So we're on 606. That's the biomarker bill.
Move on to pass.
Second that.
Are you ready for that?
606.
Biomarker bill.
Yeah, I know.
So Senator Birdsell. Left me.
All right. That was, oh, this is just like you did, I made it just for Medicaid.
Yep.
Okay, I'm good.
So we have a motion and a second, correct? Do we have a motion and a second, Sophie? All right. Any further discussion on 606? Now, I did make a note here. I just noticed this, that on the amendment,
To remove.
yeah, to remove the reference to RSA 420J.
But we talked about that earlier, where, because it says the state Medicaid plan shall cover biomarkers as defined in. So it's just a definition.
Okay. So you're fine with that?
I am.
All right.
Yeah, I have the same note.
Yeah, it said on line 26, remove RSA 420, and then on 32, J27 again.
But it's defined in, it's just referencing a definition that's in RSA 420.
John, is this a problem?
The short answer is no, it's not.
Which is what we have here.
Yeah.
Yep. All right. So a motion and a second. Any further discussion? Oh, yeah, that's true. Good point. Thank you.
I move amendments,
0213.
that's it, 0213F.
I'll second that.
I third it.
So on the amendment, any discussion on the amendment? So on the amendment, all those in favor say aye.
Aye.
Any opposed?
Move on to pass as amended.
To pass as amended. Any discussion? All right, Senator Birdsell seconds that. All those in favor say aye.
Aye.
Any opposed?
Consent.
Senator Abard moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed? And Senator Birdsell will take that one out. All right. HB 349, practice of optometry. I'll move on to pass.
Second?
I think I heard Senator Birdsell first.
Oh, she's just repeating that.
Senator Front.
I mean, Senator Prentice. So any discussion on 349?
Just wanted to, we received, you all should have received a letter from,
Turn your-
a letter from Christine Aben I spoke with Dr. Emery, on Friday. And they have, it looks like it's called, licensed proctor experts that review all of the procedures. And according to this, they're going to ensure that there is a, someone who has specialized or has done this procedure in there. So that eliminate, for me, that eliminate, and these proctors do not get cycled out like you do on the board.
Mhm.
So that's why I'm okay with this.
And do you want to speak to, I know you and I spoke about, there was another optometry bill coming. And
Yeah.
if we need to put that in statute, we will
Exa-
do that on that other bill.
Yep.
All right. And then Senator Prentice, I know you and I have spoken about this as well. If there's anything that you felt needed to be added to that, we could do that on that other bill coming.
I appreciate that, and I just wanted to, it ties into what Senator Birdsell was just talking about, state for the record, that there was a discussion about completing competencies, and I want to point out that when there's a new procedure like this, and I've learned new procedures on top of my certification, the competency when performed, if somebody, and that's why you have to have appropriate proctors, if somebody is not meeting the standard, then they don't automatically pass just because it says there's a competency. There's an assessment that goes with that. So I just want to clarify that it's not just a move you forward. You need to pass the competency, and that's going to be up to the folks that are actually proctoring this and prepared to. That's been my experience. I just wanted to clarify that because I think it's important for the public to know. Thank you.
And I think the whole idea of, I don't want to confuse the term proctor because in the bill, there's a requirement for proctors to oversee the individuals who are becoming certified. But our discussion on proctors is speaking more to a board level oversight of the licensees. So if there is a problem, there's someone on the board that can, or affiliated with the board that can add their expertise into that.
Which is like the next step up.
Yeah.
But I do think for just clarification, I want to make sure that everybody knows that competencies aren't just a natural, like you do it just because you've done it, you're all set.
Yep.
You actually have to prove that you can do this.
Yep. So the motion is ought to pass. Is there any further discussion? I'll call the question. All those in favor say aye.
Aye.
Any opposed?
Consent?
Senator Everard moves consent. Senator Birdsell seconds that. All those in favor say aye.
Aye.
Any opposed? And I'll take that one. Senator Prentice.
Yes.
SB 480, physical therapy. I know you were working on something. Do you have something?
Not for today.
Okay.
I met with the plans on Monday, and the OTs and the PTs. Cam Lapine actually provided me with a red line document late yesterday, which is a proposal from the plans, and I just need to review that. So I would expect the next time that we meet, that we will have a proposal in hand.
All right.
Either way, either theirs, mine, or ours. Thank you.
Yeah, sounds good. Let's take a look at 546 relative to health carrier network access monitoring.
You said 546.
Actually, I had a note on here that Senator Rosenwald asked to hold this until insurance department rules are released. So
Yeah, that's what I got.
yeah, let's hold off I won't do anything with that. We'll bring up another Senator Rosenwald, Bill 545, financial eligibility for Medicare saving program.
I'll make a motion not to pass.
Second.
Motion from Senator Prentice, second by Senator Avard, ought to pass. Open for discussion.
Chair Rochford.
Yes.
I think that, I mean, we've seen in a previous session, Senator Rosenwald introduced a similar bill. And so she has worked on this to target it more, to help to bring the fiscal note down. And I also, having an elderly parent living independently, it was the testimony that we heard from the different advocates in particular, and how I want to focus on the advocates really rung true with me about how we could actually save the long costs by this approach, because this keeps people at home rather than them going into a care setting that could be more expensive. And that's why, that's one of the big reasons that I prefer this. So whatever way we go, but I wanted to bring that up.
We are looking at 2.3 million.
I know.
For 27, 28, 29.
You had one person signing in opposition.
Oh, I'm sorry.
So I had some concerns about the cost of this, but I know that she did work on this a year ago. She brought a similar bill with a price tag of $14.3 million. She's got this down to $2.3 million. It removes asset ceiling. It removes administration of HHS, doing a lot of other issues with it. Obviously, I think that the price tag is a concern, but I think if this goes to finance, Senator Rosenwald is on finance, she can make her case there. That's my feeling on that.
Oh, Julie Smith didn't want this.
I know, it builds you the finance.
It's going to go to finance.
Considerations,
It's going to be further worked on.
Do what you gotta do.
So any further discussion? So the motion is ought to pass. All those in favor say aye.
Aye.
Any opposed?
Nay.
So we got 4-1. Any opposition to consent?
Nope.
All right, I'll move consent.
Second.
Senator Long seconds that. All those in favor say aye.
Aye.
Any opposed? Senator Long, you're on this bill. I'm
Yep,
going to let you
I'll
take it out.
Finance will have the final say on it anyway.
Yes.
Well, I might as well put my stake in the ground now.
Yeah. So Senator Avard, you had a couple that you were holding on to. Okay, you still want to do that? All right. So we're gonna hold on to that one. We're gonna hold on to that one. Do we want to talk about 340B drug pricing?
I'm pretty similar.
When was that?
477.
I think interim study or ITL.
477. Now, I have not connected with the prime sponsor on this lately.
Relative to increasing transparency in the 340B drug pricing program.
Yeah, the 340B is another layer of government and all that kind of, this is a really complicated dogfight. And I'd say interim study on this one.
So I would second interim study.
So I got a motion for interim study by Senator Avard. I got a second by Senator Prentice. Any further discussion?
If I may, I mean, I'm more inclined for an ITL. In my district, there are four facilities that have reached out to me about this, that are hospitals that are opposed to it because of, you know, their argument is, and I agree with them, that there is already a layer, an appropriate layer of compliance and monitoring that is available, and that this would actually almost like put another layer that's not necessary in. So it's not like it isn't being done. And I appreciate the sponsor's intent, and I'll go with interim study, and maybe we can see what comes next.
So, you know, I think that, you know, to your point, Senator, we had a bill like this last year, which was kind of like from the other topic of it. And the discussion that we had last year is this is a federal program set up by the federal government between drug manufacturers and hospitals. And although I like the idea of transparency, because I quite frankly wonder where the money is going, but the way I look at it, it's not our program.
That's right.
Yeah.
It's not our, it's not, who are we to do that?
We're gonna have oversight over the feds.
Yeah.
Hello.
Yep.
And he hasn't gotten back to us on anything. I thought he was gonna work on something, but we haven't.
Yeah, I have not communicated, to be fair to him, I haven't communicated with him, but.
Yeah, so I think interim study would be the best.
All right.
So we have a motion.
I got a motion and a second. Any further discussion?
It does,
Yep.
to Senator Everett's point, it does allow if we move this interim study, it does allow the prime sponsor, before we're done with our business session, to get back into this. Because there were some things like, we did an anti-discrimination in the 340B program a few years ago, which, you know, is mentioned in here and doesn't need to be in here because that's already in law. I mean, they were, the sponsor, you know, he seemed very open to, you know, the testimony and making the necessary changes. So I trust that he will work on this. Thank you.
All right. Very good. So any further discussion? So the motion is interim study. All those in favor say aye.
Aye.
Any opposed?
Consent?
Senator Abar moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed? All right. Senator Abar, do you want to take that one out? I'm giving you one today.
I wasn't gonna say anything.
All right. Let's see. All right, another bill on transparency. Senate Bill 476. So this is the same sponsor. I did speak with the insurance department there. They were, and I'll move interim study on 476.
Second.
So we got interim study. So I did speak with the department on this. And there was some concerns that this would have some unintended consequences. In fact, when I spoke to the insurance department, they felt like this could actually take a step backward in transparency than where we're going right now. They felt that rulemaking is already in process to address this, and things like health costs at NHID insurance department, they have this information. So, you know, I think that interim study is a good move because they are working on this, and if the department doesn't produce what we want it to, we can bring it back and address it. Any further discussion?
Nope.
All those in favor, say aye. Any opposed?
Consent.
Senator Abar moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed?
What is it, ITL or IS?
IS. And I can take that out. Let's see. We're gonna hold on to the Medicaid work requirement. Rate setting parity, that's you. That's SNAP. We're working on that. 614, Senator Ricciardi's getting back to me on that. 645, I'm working on an amendment for that. That's income eligibility for New Hampshire Child Care Scholarship. I spoke with the prime sponsor just about an hour ago.
And?
I told her I'm gonna work on an amendment.
Okay.
That's you.
646.
Six 46.
That's yours.
Which one is that? Oh, yeah, we're working on that. We're gonna hear.
Okay.
Let's see what this one is.
Which one are we on?
We're not on anyone.
Not anyone right now. Okay, 640 or 548, I'm told there's an amendment coming on that. 441, I just wanted to talk about that real quick. You got an amendment that I did for 441. And this was the amendment that was given to me by the New Hampshire legal department. I think either Senator Prentice or Senator Birdsell, I can't remember, reached out to New Hampshire Municipal Association.
I did.
And I had their thoughts come back yesterday. I have not had that drafted as an amendment, but I know we've all seen it. I don't know what your initial thoughts were on that.
Yeah. It's had to do with the MOU, right?
Yes.
Yeah, I mean, I do want to point out, and I did talk, when I talked to NHMA, and I brought this up during a hearing, that municipal governments can already enter into agreements with each other for services. They have their intergovernmental agreements. They often do it for infrastructure-related issues. So my conversation with NHMA, I wanted to make sure, but I said, isn't there already the framework, legal framework for these communities to do this? And the answer was yes.
But what happens when you have someone from out of state drops them off into Manchester?
And we heard that there were, 5 times? Senator Long lives in Manchester, so I'm gonna let.
Well, we were
I'm so sorry.
successful in, somebody had dropped off someone from Maine.
Really?
And we were successful in getting.
Now, there was, the lawyer that spoke at the end, remember his conversation, how that, wherever they were from last, that's their domicile. It doesn't matter if they were homeless or not. And so that sending town should be responsible for the care for a certain period of time. I don't know, was it 30 days or something like that?
The chief, I asked the chief the question, there were 5 incidents that he could recall. One of them was the Maine one. And actually the person from Maine was in a wheelchair and a breathing apparatus. And, was dropped off at families in transition that had no room.
That's crazy.
Yeah, and so they were, actually it was a police, I forget the name of the town, from Maine, that dropped her off. And she was brought back like within 2 or 3 days.
What? Yeah. Where'd she go in the meantime?
It's across the border.
No, she didn't. The police from that town brought her.
Yeah, we had a spot for
Maybe
her.
we should stop the police from out of state whenever they come in.
Well, online, families in transition said they had room.
Oh, they did.
That's why they brought them down.
Oh, I see.
Wow.
Okay.
I think, if I may, I mean, I do think that this was sorry, I started talking before I had.
Go ahead.
I got a little ahead of myself. So I think that the sponsor's intent in addressing a concern that has come up in our community, I respect that. And I don't think we can stop, even if we were to pass this. I think there's still going to be times where people who are from out of state that have no knowledge of our laws, this could happen in, to any community. But I just want to, the underlying, they can already enter into these agreements is why I think that structure exists. I mean, not why, but that structure exists already for communities. So I just want to, that's where I'm really focusing on. If they can already do it, I don't think that we need to do this. I think people, if they're going to come over the border, I don't know how we can stop them. And I appreciate the intent, but I actually think we've got a mechanism for this. So that's my position on it. I mean, I don't want to vote. I don't want to ITL it. I prefer to interim study it. If you all want to pass it, that's fine too.
Senator Long, you said something to the effect that Concord might do the same and Nashville might do the same.
If I may, Mr. Chairman.
Yeah, go ahead.
there's a perception in Manchester that because of services that we offer, a lot of people are coming to Manchester for those services. The homeless and the substance use disorder people that are coming to Manchester, they're not asking for services. So
Right.
I don't know why they would come in for services. But when you speak to homeless people in Concord or Nashua, there were some of them that are from Manchester.
Right.
So I think the grass is always greener on the other side, so I'm being moved in Manchester from the spot I sleep in, so I'm gonna try Nashua or Concord. You know, so I think it's a state issue,
Yeah.
not one municipality.
Can we hold on for one moment?
Yeah, we can sit.
So we can talk to Victoria a little bit more.
Yeah, I mean, I'll percolate on it a little more on the amendment.
And I would ask you to look at the amendment that I did, and also look at the amendment language that the municipal association sent forward. So they did, they responded to me. I asked Sophie to circulate that yesterday, so you have it.
You know, I just need to pull my computer out. I looked at.
Is that the revised? It says, 0446 as revised.
Yep, you should,
Oh, here it is.
yeah. So to speak to your point, Senator Prentice, the municipal association definitely weighed in on this and with language. So, but I think it would, in all fairness, I haven't had time to look at their proposal, so it might be benefit.
Are we looking at 446?
41.
No, the amendment.
Yes. That amendment came from the New Hampshire law.
Yeah.
And then, yes, legal assistance.
Yeah, he did a good job.
And then yesterday, Sarah Burke Cohen emailed us, and I asked Sophie to circulate that, some language that the municipal association circulated. Did you get the attachment to that? Yeah.
Yes.
Okay, and that was circulated to the committee members? All right.
Yeah.
All right.
So this is what it looks like. We got it, it was on our desk today.
Oh,
Are we keeping you up?
yeah. No, I think we got it.
I'm just looking it up. The municipal association has,
Yeah,
is good with this. I mean, that they're looking at this through a similar lens. Oh, man, it says on the side.
So we'll hold on that one.
The changes are in red, like reading the Bible.
Yes.
All right, I'd say that. So has anybody talked to Victoria about that?
No, I talked to her about the initial, she was on board with the initial amendment but this just came in yesterday. And I'll circulate that to her.
Thank you for your patience, Chair.
Oh, sorry, this is what it looks like.
I gotta have it done.
Okay.
If I said I didn't have it, there's somebody watching on the screen that would have my head.
I did have it.
Marie.
That's all I have. I got a lot that are needing some work. But, all right, a motion to come out of executive session. Do I have a second? All those in favor say aye.
Aye.
Any opposed? We're out of executive session. So with that, we'll adjourn for the day.
Awesome.
Okay.
Mine's on consent, right?
You'll get it out of there. You do a really good job with those. Cam used to do a really good job. He's no longer with us. So I used to call him
Yeah,
Superman.
we were afraid of Cam.
Yeah. I used to call him and Kyle Superman. We gotta come up with something for you, like Wonder Woman or something. Amazing how you do what you do. Just amazing. All right. Oh, wow. Is that my body? It's in birthday, you're right, you might be saying.